Um, then at 10:30, Dr. Simmons is going to come in and do a review for some med-surg that she thought was important for you. And I've already uploaded her PowerPoint, so I'll only have you an hour and a half. But she'll be here around 10:30. And that PowerPoint is available for you. So when she comes, you'll have that already. Right. When you are finished with her, obviously it'll be time to leave. So I probably will not see you again until next week on Wednesday when we have our ATI specialty adult med surg will be first, followed by pharmacology. And those are the last two specialties that have to be done for NUR 449. But you can always email me, and I'll keep in touch with emails and things of that nature. All right, so are y'all all excited and ready to kind of think about that comprehensive that's coming up? Oh, I didn't see anybody say yes. Okay, thank you, Grace. Thank you, Grace. I see Grace saying that. Yes. Any questions about what we're planning on doing today? It's going to go by really quick today, these 3 hours. All right. So I want to get you all excited about this. All right. So you should be able to see my presentation here. And again, I'm going to send it to you. Okay. So basically what I've done is I've taken some of the most common concepts that I do see on the comprehensive predictor as well as on the NCLEX. And I'm just going to go through this. The first 70 slides or so, I'm going to move really fast, and I won't go into detailed discussions like a lecture, but you're going to see some of the content. Then when we get to 74, I hope you're ready to be quizzed again on your EKG strips and some other cool things and acid-base balance. So we're going to start doing some of that together because there's lots of questions and that I have put in this comprehensive predictor review as well for you. All right, so I want everybody as much as possible to please participate because this now is for you to get you ready for that comprehensive. I am excited for you. All right, you're graduating soon. All right, so let's go ahead and get started. The first thing, I just wanted to encourage you that you have come 4 quarters, almost 4 quarters, through a very tough and rigorous nursing program. You are well prepared for that NCLEX, in my personal opinion. So we just want to encourage you to keep smiling, to keep pushing through, and be sure you attend your ATI reviews and all those things that we're going to be having for you. Remember, at the end of this quarter, it's a Tuesday, Wednesday, and a Thursday, you'll be having that ATI live review, and I'll be sending out information for that. And it's going to be a few weeks yet because I have to wait to receive that material from ATI itself. So you'll be getting some information and emails from me to get you all started and prepared for that review. All right. All right, I broke it down into categories. The first one is fundamentals. Now, there's lots more in fundamentals, of course, than what I have on here. There's just no way we could cover everything, but I just wanted to point out some things, and I'm not going to, again, make any major discussions with this as well. All right, so basically fundamentals, please remember about your commonly used abbreviations. This is one thing I have seen that has been a challenge on many of the exams that I have observe. So be sure that you're remembering what the Joint Commission says, okay, about those types of abbreviations, which are common ones. Don't forget informed consent. What I've done is given you some questions. So if you can answer these questions, you should be fine with this informed consent. What to do with valuables is another thing that pops up from time to time. So be sure that you're understanding what do you do with your patient's valuables. Safety at home, electrical equipment, of course, we are much aware of home safety because remember, NCLEX is all about safety for your patient, regardless of what setting it is. So electrical systems. All right, there are alternatives to restraints. As you do remember, restraints are going to be the last resort. And you want to try other diversional activities before you tie someone down. All right, and it's very, you have to every 30 minutes, at least every 30 minutes, you have to check the neurovascular status and all of those things. And at least every 2 hours, you have to be sure that you are taking the patient out of restraints, doing some range of motion and those types of things. Okay. Don't forget that we do large volume enemas. You may remember some of this from way back in fundamentals, right? So this is just some key points that I put up here for you, just as a reminder. I'm sure all of y'all probably know this information, but it is a reminder in the event that you've kind of forgotten some of this basic information. Home care tracheostomy care. We also teach our patients how to take care of those trachs at home, and perhaps maybe some of you have already done some of that teaching to go home. However, this is what ATI is saying that's important. So I'll put these up here for you to kind of review. Remember, I think this is important here to remember that suctioning technique at home is not sterile. It is sterile in the hospital, right, but not at home. I think that's a key right there. All about wound healing. I'm not going to go through the phases of wound healing, but the material is here if you need some pathophysiology, or excuse me, some physiology information on wound healing. Your exams, ATI exams, as well as your comprehensive may have some physiology or pathophysiology questions. So this is one that I have seen in the past, or something associated. Remember, I don't have access to the questions, but I have access to the concepts. Okay. All right. And these are just phases of wound healing. And I'm just going to show you those and let you read through those at your leisure. Don't forget, postural drainage positions is definitely something that is testable on both your NCLEX and all your exams. So in order to remember that gravity is what we use to move the drainage in the patient's lungs, all right? And we never administer postural drainage after a meal. Makes sense, right? You know, we don't want them throwing up on us or choking or having aspiration issues, okay? All right, so I have a question for you. Which position would best facilitate drainage from the apical segments of both lobes? Where's the apex on the lungs?
Would that be a D?
Okay. Anybody else? Okay. The answer is C. Let's look at why it's a C. Notice the patient is leaning over here, and so they're not getting straight line drainage from up here in the apexes because the patient is leaning over. In this case, the patient is sitting straight up, and we are working on these apexes, which are right here, right above the collarbone. All right, so that's why C is the best answer. This does look like it should be, but remember, it's the angle of the patient. Remember, we want a straight line down as much as possible. All right. Iron supplementation and anemia. You've learned about anemia, iron deficiency anemia. Be sure you're familiar with the foods that goes along with iron, the sources of foods. That's real important. You did have nutrition in topics, so they do tend to ask questions about nutrition on these exams. All about blood transfusion products. I don't know if Dr. Simmons is going to go back through some of that material. We learned basics and fundies, and then I imagine that you have had some of that in Med-Surg as well. But I put those up here. And the question I have for you regarding platelets, why would you use a short tubing for platelets? What do you think?
If the tubing's too long, it might clog the tubing.
Okay, that's a really good idea. Absolutely. The biggest reason is because they're so fragile. The longer they have to drop down a tube, the more danger of them breaking open and splitting and being damaged. So that's one of the main reasons we use a short tubing for platelets, because they're extremely fragile. Of course, there's a little bit about plasma, white blood cells, of course. And there's washed red blood cells, just giving you some basic information. how to prepare and how to give blood administration. These are the common things. The signs and symptoms of transfusion reactions, there are multiple types. We call it mild allergic, febrile, anaphylactic, as you can see here, and I've given you some points and some tips to kind of just review if you have kind of forgotten some of that material. And here's another one. Okay. And I think I got in even more detail. Febrile. These are, remember, these are interventions. Very important to know interventions, nursing actions, because your NCLEX is going to ask you more questions about what are you going to do for the patient before you call the doctor. So it's all about, it's all about what we as nurses do. Okay. So I've asked you some questions here. All right. And I did not put the answers, so you have to find the answers. All right. I'm sure you can figure those out. If not, let me know. So you just fill in the blanks here. Okay. Circulatory overload. We've studied that quite a bit in nursing school. So what would the nurse do if a client has clinical manifestations and symptoms of fluid overload? All right. So you think about that. Patient has circulatory overload. We know that the older adults is more at risk for developing that fluid overload, particularly if they already have a heart problem. So you're going to hold the other IV infusions. The question I have for you is why? And so the big question here is, what would you do if the client has these symptoms of fluid overload? Okay. And I've given you the answers. Hand washing. Sometimes, hand washing is such a simple but yet a very serious task that we have to do as nurses. Just a little reminder of how to do hand washing. Common IV sites. You just had some IV studies this quarter in your ClinApps. So you want to think to yourself, what would you consider when you're choosing an IV site? And what are the basics of assessing an IV site before you actually give a medication through that IV site? So these are the most common ones that we do use here. PCA pumps and opioids is also important, particularly with not so much programming the PCA, but definitely patient education. What should we do if a patient has a PCA? And we want to think about what are some of those adverse effects and even side effects that you need to monitor as a registered nurse during the infusion of a medication through a PCA pump. And I've given you a list. Okay, so there's a whole list here that I have given you. There may be others. It also, remember, it also depends on the medication that you are infusing through the pump, whether it's a fentanyl, whether it's morphine, or some other medication. Be able to understand how to read and understand a routine analysis. You may be given an analysis or actually something similar to this, and you have to kind of figure out if everything is okay with the patient, and may have to answer a question based on your lab results and charts. There is a whole bunch of common concepts here that I've listed here for you. If you're not familiar, if you're kind of not sure about some of these, most of this, of course, is going to be in Fundamentals of Nursing. Be sure to look it up if you've kind of forgotten what are some of the aspiration precautions and the different types of isolation. This is all part of your fundamentals class. So on nutrition, there's a couple things in nutrition I wanted just to point out to you. What does vitamin A do? And why is it possible to develop a toxicity to vitamin A? Can anybody answer that question? Why does vitamin A have a possibility of developing toxicity?
Is it because it's fat soluble?
Yes, very good. Because it's fat soluble, A, D, E, and K are fat soluble vitamins. And it's hard to get rid of those through the urine, all right? Everything can become toxic, right? And of course, the other question I have for you is what food sources might you recommend for vitamin A? And I think I gave you the answer to that as well. Some information about protein, Kwashiorkor versus marasmus. There's differences between the two, so be sure, particularly because this is part of your pediatrics, and of course nutrition about protein, so be sure you can tell the difference between the two. And so that's why I put this picture up here. Basically, it is extreme protein deficiency, and you can see the difference in the way the babies look. Diarrhea that's associated with cancer and HIV or AIDS. We have to think about what can we do to help patients of any form really that has diarrhea. And of course, we would want to consume foods high in pectin. Does anybody know why we would consume foods high in pectin?
For nails and collagen formation.
Okay, that would.
For nails into other connective tissue.
Okay, good. It also increases the bulk.
And it absorbs water.
Yes, it increases the time in the colon. Remember, this patient has diarrhea. That's very good, Steve. Excellent. So again, just a little bit about diarrhea, and there's much, much more that we've studied in the past. There are some infants and diets, and I want you to tell me if this is true or false. Are you ready? Breast milk, infant formula, or a combination of the two is the sole source of nutrition for the first 6 months. True or false, class? I see some head shaking. Yes, absolutely, it is true. Semi-solid foods may be introduced at 5 months of age.
True.
It's actually false. It's after 6 months. Why?
It's not when they learn how to swallow because of the way their tongue moves.
That has something to do with it, but really it's the GI tract. The GI tract is slowly starting to develop. It takes time for it to develop and be able to digest food. So that's why we wait till after 6 months. All right, this is ATI information, so that's why I have included it here for you. Other things are coming from other resources, but this is ATI. All right, so iron supplementation is recommended around 4 months of age for infants exclusively fed on breast milk. True or false?
False.
It's true. Yeah, because the baby is not going to get enough iron in the breast milk. And so usually they do like to start beginning to supplement that around 4 months of age, right? And then cow's milk should be introduced after the first year of life.
True.
Absolutely, that is true. Okay, good. A little bit about infants and diets. A little bit of information as well on Crohn's disease, these types of inflammatory processes. And so I've given you some information, some description of what regional enteritis means and the signs and symptoms of that. And just a picture here to just remind you about the physiology and the anatomy part of how food is absorbed into the body. And it's a good thing to review something like this type of chart, because remember the pancreatic juice comes into the duodenum here. Bicarb and enzymes are part of that. And so remember that alcohol goes directly from the stomach to the bloodstream. All right. That's one reason people get drunk real fast, because it doesn't have to be metabolized through anything. It goes straight to the bloodstream. All right. So nutrition for Crohn's disease. I've some additional information, what to avoid, what to use, what kind of nutritional therapy is needed for Crohn's disease. High calorie or high protein is usually the diet that's recommended. Okay. Notice here, during acute episodes, you want to give some bowel rest or a low fiber diet. Preferably initially when it's very acute, it's going to probably be NPO for a while, and then they'll slowly put it back on a low fiber diet afterwards. This just talks about the nutrients that people with Crohn's disease has a lot of problems with absorption. All right, I've touched a little bit on Med-Surg. Dr. Wheeling will cover the details of what she wants you to remember in Med-Surg, but I did put some things here. Part of this is delegation. Not only do you learn it in Med-Surg, but you learn it in Fundies, you've learned it in leadership. So always remember, this is one thing that they do look at. Prioritization and delegation is massively important to remember. Okay? So you have to think about who you're delegating to, what is their roles, what can they do, have they been educated on that particular task. And remember, you cannot delegate assessment, diagnosis, planning, and evaluation because it requires nursing judgment. For LPNs, they cannot assess or create a nursing care plan. However, they can add information, they can collect some data, but it's the registered nurse who has to complete the care plan. They can't hang blood or experimental drugs or chemo. Just remember, NCLEX is not the real world, all right? Go by the book. And of course, you can delegate activities when a patient is stable. If they are unstable, or we're not sure what's going to happen, you cannot delegate that material. For prioritization, you're going to use Maslow, you're going to use ABCs and whether the patient is stable or unstable. You also can consider being chronic or acute problems. So lots of ways to look at prioritization. So which of the clients should the nurse on a pediatric unit assign to an LPN? Anybody want to try and answer?
That'd be 2.
3.
I hear 3 and I heard a 2. Okay, so let's take a look. It is 3. Okay, let's talk about 2. If they have had a gastric lavage because they took too much Tylenol or acetaminophen, that patient is still unstable because we don't know the effects of that Tylenol, because remember, it's already been absorbed into the bloodstream and it's gone to where it's going to go. So it could be that the patient, something could happen seriously to the patient. So we cannot delegate that particular patient to the LPN. However, with a 6-year-old, the femur is a fracture, they're in balance, suspension, traction, and there's predictable outcomes for that. So we, based on the rest of these, that's the most stable patient that we have. A patient with a laryngotracheobronchitis who has a tracheostomy, that's obviously a respiratory concern that we might have. And the same for the observation of a young 10-year-old who has had an acute asthma attack. We don't know if that could occur again. So we need to be using our observation skills as nurses to be able to determine if there's any problems with this patient. Remember, as an RN, your skills of observation and early intervention is really what helps our patients stay safe. All right, so let's do it. So a nurse is caring for clients on a cardiac unit. Which client should you assess first? The client with angina who's reporting chest pain, the client diagnosed with CHF who has a bilateral 4+ peripheral edema, the client diagnosed with endocarditis who has a temperature of 100 degrees Fahrenheit, or the client diagnosed with aortic valve stenosis who has syncope. So if that was you going into that patient, you're fixing to go out to transition, you're going to have multiple patients. Eventually, when you're in transition, you have to learn how to, or begin to learn, what should I see first? So what do you say?
Chest pain.
Which one?
Chest pain.
1.
I hear 1. All right, very good. Yep, somebody having chest pain, we definitely need to be concerned. Obviously, with a CHF, it's expected they're going to have some edema. With endocarditis, we expect a temperature. And aortic valve stenosis, yeah, they're going to have some syncope because the blood is not going to get through properly, and so that oxygen is not going to get to the brain, which then leads to dizziness and fainting potentially. Okay. All right. And there's all your answers. Okay, so the nurse has just received the morning shift report. Which client should the nurse assess first?
Mm, 4.
Okay, so the client with deep vein thrombosis who is refusing to stay in bed. Yeah, excellent. Y'all ready for this? Y'all doing great. Okay. Why do we not want to pick the other 3? What's the rationale for not picking number 1?
I mean, because they're gonna have venous stasis no matter, like, if they eat high protein. Like, the protein meal diet is just gonna make it, make it hopefully get better.
Mm-hmm.
It's not gonna make or break it, you know?
Okay, excellent. What about number 2?
Same thing.
Absolutely. They've
I
already
mean-
got the problem, right?
Yeah.
Okay. What about 3?
And then, I mean, same thing, like, these are all interventions. The 4th one,
Mm-hmm.
like, them getting up can dislodge it, and then it can become worse. Or, you know, like, become a PE and go into their lungs and stuff.
Oh, excellent, excellent. So everybody understands those concepts. These are just basic concepts. Very good, excellent. All right, here's another one. The charge nurse is making assignments on a medical surgical unit. Which client should be assigned to the most experienced nurse?
I'm gonna say 1.
Okay, I hear a 1. Anybody else?
I would say that one as well because they're more at risk for aspiration and it's the lower. So I feel like that's the more dangerous one. The other one is like a surgery. Another one's a 4 out of 10. And then bilateral wheezes. I guess there's interventions we could do, but they have wheezes.
Okay,
And all of them have, like, all 3 have been already diagnosed. The first one hasn't.
okay. All right, let's take a look. It's number 3. Let's take a look at that. Okay. First of all, someone who has dysfunctioning of the lower esophagus and they're having regurgitation, we know that could be a problem, right? But someone who has the GI reflux and they have bilateral wheezes could have already aspirated. That's why number 3, airway, is got to be done before we worry with someone who's getting some reflux from an esophageal dysfunction. So that the key here to answer this one is that they have this problem, but they have a breathing issue. They have bilateral wheezes. We must take care of that problem before we worry with this person up here. Make sense, class?
Yes.
Yes, ma'am.
All right, great. All right. Okay, I think I accidentally gave you the answer already. All right. So this is the nurse preparing to administer meds. The time is 7:50 in the morning. Which medication should the nurse administer first? You had DIG, furosemide, propoxyphene, and acetaminophen. Okay. So the answer is what? I kind of gave you the answer already. It was an accident. I didn't mean to do that.
Acetaminophen.
Yes. Yes, and the reason for that is because it's a routine med. The DIG is a routine. The Lasix or the furosemide has about an hour leeway, remember? And then the Darvon or the propoxyphene is not due yet. So that's why we got to get that acetaminophen in. Okay. All right. The client is admitted to the emergency department with a 3rd-degree burn over the front of both legs. Which priority intervention should the nurse implement?
2.
2.
Okay, I hear some y'all I'm very proud of y'all. You're doing wonderful. Absolutely. Get those IVs in because this patient could have a serious circulatory collapse if we don't. All right, good job. We're going to do all of these anyway, right? We're still going to do the sterile environment, the IV, most likely antibiotics because it is a burn. And we are definitely going to assess their pain level. But the most important one will be getting that IV in. All right. You have received an end of shift report. In which order should the nurse assess the clients? Who would you assess first? This will take you a couple seconds to think about.
Two, maybe.
Okay. So you're going to assess number 2 first. All right, let's take a look at these. I'm going to go ahead and give you the answers so we can talk about them. Absolutely. You did good. Yes. We're going to make sure that the CVC is working okay. What's the next one? And then who are you going to go see?
One.
Perfect.
And then 4.
And then 4.
And
3.
yes. All right. These are what we call step ordered. So this is at a prioritization question. So you did really well on that. So the client comes to the emergency department reporting retrosternal chest pain and shortness of breath. Which action should the nurse implement first?
Three.
I hear a 3. Any others? All right. You are correct. Yeah. Very good. One thing to kind of remember in nursing, even though we have 4 responses, you know, in the real world of nursing, most of this is going to be happening at the same time. Does that make sense? I mean, somebody's going to be getting an ECG, somebody's going to start that IV, of course, and somebody's going to go get that aspirin. So all of them are correct. But because we do have some shortness of breath here and chest pain, we're going to give that O2. But you have to choose one. All right. So that's correct. All right, here's a change of shift report. Who will you see first?
Four.
I hear a 4. Any others?
thinking number 1 because they're crying with back pain, but that's expected if you have kidney stones, so never mind.
Okay, let's take a look. That never mind was correct.
Oh, okay, so pain.
Okay, why? Think about why. Yes, we're going to have to give the red blood cells and we need the IV, but we have a patient who's hurting really badly. We need to go in and assess this. They're probably, you're correct, they're going to have back pain, but they're crying. So we have to think, what can I do to help this patient have less pain? And then I'll go and take care of this IV for the packed red cells. Okay.
If it didn't say crying, do you think it would still be priority number 1?
No, it would not. Not necessarily. However, when you have a question like this and we try to change it, I would have to change. I would definitely not use it that way. I would have to change up here the scenario to make it more doable to answer that question. But yeah. But this patient is definitely in some pain, so we got to take care of that pain, and then we'll take care of some of these other things. Okay, good job. All right, so some of the other major concepts within Med-Surg I recommend you take a look at, and I've listed them here for you. And there's many others, but these are just some I've seen. Okay. Lots of them. By the way, the heart sounds and all there's links to those if you want to listen to sounds. Okay. And here's a few more. All right, let's take a look at mental health. So what I want you to do is guess the substance based on the withdrawal symptoms. Okay. So for the first one, this particular symptom can occur within 24 hours, and you have headache and nausea, irritability, those types of things. The second one, you have a craving. The patient would have a craving, depression, unpleasant dreams. So what do you think this first one might be? Remember, these are withdrawal symptoms. Any guesses?
Alcohol.
All right, let's take a look. Caffeine. Yeah. Alcohol, usually we start seeing problems with alcohol in 72 hours. But with caffeine, if we don't get caffeine within 24 hours, sometimes these are the symptoms that we might see. And of course, what do you think of this one? Any guesses? I could have given you a list of the substances, but the way the NCLEX will write their questions is they're not going to tell you the patient is in caffeine withdrawals. They're going to give you, obviously, symptoms, and then maybe ask you a question related to that. So this one is cocaine. You might want to review these. So the first one here is there's no withdrawal manifestations, maybe some death. And the second one, the patient sleeping, depressive, and there could be some tachycardia with that. So I'll go ahead and give you these because I would just think you need to just be reviewing these. So this one is going to be inhalants or huffing. Okay. Sometimes even with somebody who has done a lot of huffing like gasoline or some other substance, and if they already have a depression state, they can actually commit suicide because their brain changes. There's damage to the brain cells. For this one here, amphetamines. And remember with amphetamines, everything gets speeded up. That's why we see this here, tachycardia and elevated BP. The amphetamines are not necessarily life-threatening, as you know. However, if there's a problem with their heart, it can certainly cause death.
So I do have a question about that.
Sure.
Okay, so the huffing, because that was one of our questions on the ATI, and I could not for the life of me figure out if their pupils would be pinpoint or if they would be dilated.
Okay.
Like, I was trying to, because I know cocaine, I think, you're dilated.
Okay.
So can you tell me, can you tell
Uh,
me if they're pinpoint or if they're dilated?
Oh gosh, let me think. I'll have to look that one up. If there was,
Yeah, it was bothering me so much. I was like, oh my God, like, are they pinpoint or are they dilated? Like, I do not remember. And I couldn't work it through.
sympathetic nervous system, stress, would that dilate your pupil or expand them? What happens in the fight and flight response?
I don't remember.
Oh, remember with that, if there's a bear coming after you, your eyes are going to dilate because you need all that light to see.
Okay, so is that
It's possibly going to be pinpoint, but I would have to look that up to give you the correct answer.
okay? That's what I picked. I picked pinpoint.
There you go. You got it.
Okay, like
But
because
that's
I
a
was
great
wait a s-
question.
Okay.
Yeah, that's a really good question. Yeah. All right.
Wasn't one of the choices ataxia? I thought one of the choices was ataxia, and that would be the answer, wouldn't it?
Well, I mean, I don't know the question. I mean, I can't tell you
I
about
don't know.
the
I don't know. I haven't done the remediation yet, so I don't know if I got that one wrong or not.
Yeah, I don't know. I'd have to look that up. But generally with, notice if they're slurred and they're drowsy, they could have some ataxia, right? Because they can't stand up very good. Their muscle weakness, that's a good point. Absolutely, ataxia could have been the answer.
Yeah, I think that's what one of the choices was.
Okay. All right. So y'all gonna let me know about this inhalants. I'll need to do my homework on that because I don't remember. All right. I'd have to look it up myself. All right. So here's your hallucinogens. I can't even say the word. Of course, flashbacks and things, and then of course cannabis. All of these things: irritability, restlessness, diaphoresis, all these things. Okay. It's really interesting. We always hear about if somebody's smoking pot or weed, they got the munchies. But in reality, the resource, I think this was ATI resource, said there's a lack of appetite. But I suppose that could happen. If they're having serious problems with their abdomen, they're not going to feel like eating, right? So that could be potentially why. Okay.
For inhalants also, I mean, what I hear commonly too is being used as nitrous oxide and whippets. I mean, it's not, we always tend to look at gasoline as the inhalant, but there are others being used. And one of the big ones out there is laughing gas in cartridges.
Amazing. And glue, I think glue's one too, right?
And glue, yeah, those are the ones, yeah, with the like dissolving capabilities, but there are anesthetic gases out there that are being abused as inhalants.
Oh, well, that would be medical people doing that, or because most people don't have access to that.
No, they can be purchased in head shops. They're cartridges.
Are you serious?
It's what, yeah, nitrous oxide is what whipped cream is packaged with. So people can inhale it from whipped cream containers, either that or buy the cartridges.
That is amazing. You have to be really
Google
desperate.
it.
They're called whippets,
lot,
Steve.
especially in Great Britain.
Wow.
Excuse me, whippets.
Whippets. Whippets because of the whipped cream. Y'all teaching me a
lot for years.
Listen, y'all teaching me a lot about that mental health stuff because I'm a med-surg nurse. But that's amazing. There's so many things out there that can really hurt our patients, right? Our people. Yeah, wow. Thank you for sharing that. That's great. I do want to find out if there's any association with the pupils. Ataxia makes sense, what y'all were just talking about, but I'm just curious. I'm going to have to look that one up. Somebody can send me an email if you find it before I do. Awesome. All right, so here's your opioids. I think one of the ways you really can remember an opioid and they're having withdrawals, sweating and runny nose. That runny nose is a clear indication that there is a problem here. They have goosebumps, piloerection, and of course, it's very unpleasant to have this particular withdrawal symptom. And of course, alcohol 2 to 3 days. Usually it's about 72 hours. All right. And we see this a lot in the hospitals, actually. Yeah. Okay. All right. Here's some other things to think about. And I just put you all, these are so many of the different withdrawal symptoms that we might see in our patients who are on unusual substances. Okay. Good. So these are all benzos, club drugs, barbiturates. So this is the kinds of things that you would see. All right. All right. What is the antidote to an opioid?
Narcan.
Yep, naloxone. Okay. How about a benzo?
Fluzamide or Fluza something.
Flumazenil. All right, flumazenil, and a barbiturate. Does anybody remember the antidote to a barbiturate? All right, let's take a look. There are none. That's very good. That's why you don't remember it. But then unfortunately, it wasn't a trick. I just wanted to know if you knew. All right. So at least you were thinking and nobody answered. So that's a good sign, right? Yeah. Notice here, all of these over here, there are no known antidotes. And so all we can do is treat the symptoms. And I've listed those for you, the ones we just talked about. All right. Good. As far as mental health, sometimes we see this question or something similar, the Wernicke-Korsakoff syndrome.
I have a quick question.
Sure.
Is activated carbon considered an antidote or more symptom support?
It's more of
activated charcoal.
Yeah, activated, I believe in most cases it's more of a symptom. It's not really an antidote. If they give, and they don't do a lot of that too, I don't think, but the activated charcoal, we used to give it for poison ingestion. Remember that? We used to give that in poison
That's what I was
ingestion.
referring to. So, but I guess it's not considered antidote.
Yeah.
It does absorb. It absorbs the toxin, though.
Right, but it's not a
So
true. It doesn't reverse anything.
It okay.
It doesn't reverse the effects. It just kind of.
I hear you.
Yeah, that's a good question. That's a great question. Y'all have some wonderful questions. So anyway, Wernicke-Korsakoff syndrome is basically a deficiency in vitamin B1. There is two types. One is together they are a syndrome, which means there's multiple conditions. So the encephalopathy is really the brain itself reacting to the lack of thiamine. It causes brain damage, of course, in the thalamus and the hypothalamus. The psychosis that comes from the lack of thiamine actually causes memory problems, and that's known as Korsakoff. So the Wernicke is really the brain effect, the physical brain effect, whereas your Korsakoff is really has to do a lot with the thinking, the memorization, the conversation, being able to talk, those things. I think this is kind of interesting. The Korsakoff may confabulate or make up information they can't remember, but they're not truly what we call lying because they really believe their explanations are correct. Right. So just a quick way of reviewing this material. I don't know if y'all had this before, but I've seen it. Okay. All right. Alcohol misuse obviously causes a thiamine B1 insufficiency. Anger management. There's predictors of violence, and real sure this is anger management and crisis management as part of mental health is a huge piece in that particular specialty. So I've given you some predictors of the violence here. Whoops, where'd it go? Oh, there it goes. And these are our nursing interventions for anger management. Important thing, give them lots of space. And don't let them get between you and the door. All right. Crisis management really is about safety and anxiety reduction. And here's some nursing interventions. We want to ask them about suicide or homicidal thoughts, of course. All right. Different levels of anxiety. And there's some risk factors here that I'm just going to let you take a look at. So here is to identify the anxiety disorders. And to save a little time, I'm watching the clock here. I want to make sure we cover as much as we can. We'll notice here that this is agoraphobia. Y'all remember these terms? An obsessive compulsive disorder. These are just different types of anxiety disorders. Okay. Agoraphobia. What is arachnophobia? Anybody know?
Isn't that fear of spiders?
Yes, there was a movie. Do y'all remember the movie Arachnophobia?
That's what means fear of spiders.
Yeah, so arachnophobia is a fear of spiders. Okay, so here's your obsessive compulsive disorder. All right, here's a couple more here. One is the generalized anxiety disorder with a discussion of it, and then the panic attacks. All right, the differences. And so how do we care for someone with an anxiety disorder? And here's a whole list of things that you can do. All right. Stay calm, for sure. Be sure that you are reviewing the major concepts. Make sure you know lithium, the signs and symptoms of toxicity, of course, bipolar disorder, depression, schizophrenia. These three right here, bipolar, depression, and schizophrenia, are clearly written in the NCLEX detailed test plan, so they expect students to know that, or graduates. And of course, your defense, the various defense mechanisms such as rationalization, denial.
Could I just interject one thing? I had to look it up on, it's a Netflix movie I just saw. It's called A Woman in the Window. The woman in the window, if anybody wants to find out about agoraphobia. It's all about this woman with agoraphobia. Just found it on Netflix and watched it, and it's pretty good.
Oh, I saw that advertised the other day. Yeah, where they're extreme fear of certain places. Yeah.
Yeah, she has it during the whole movie. It's wild.
Wow. Okay. So that would be a great movie to show in a mental health class, you know?
Steve,
right.
is she in a wheelchair? Steve.
No, not in this one. No.
Okay, I think there's a book just like that.
Wow. Learned so much.
She
All right.
got it from a trauma that occurred to her.
Oh, okay. All right. Now, we're ready to look at some lab values. Are you ready? First thing we're going to do is look at blood chemistries. Are you ready to speed respond? I didn't hear, nobody said yes. All right, well, here we go. BUN.
10 to 20.
Perfect. Calcium.
9 to 10.5.
Good. Creatinine.
0.6 to 1.2.
Nice. Mag.
1.3 to 2.1.
1.3 to 2.1. Yeah. Yeah. Very good. All right, let's look at some more. Everybody knows this one. Potassium.
3.5 to 5.
There you go. Sodium.
135 to 145.
Y'all are good. Chloride.
We don't know that one.
And they don't know that one.
90.
97 to 107. Yeah. All right. Phosphate. This is important to know. Phosphorus, phosphate.
3 to 4.
Yeah, 3 to 4.5. I forgot to put the unit here. And total cholesterol.
Less than 200.
Less than 200.
Okay, very good. Less than 200. Wow, I'm very impressed, class. All right. And of course, glucose. Basically, this is what we mean about the glucose, and of course, glycosylated hemoglobin. All right. Notice that 7 is what we want, or below 7 actually. But again, values will vary. So on if you are giving any lab values, even on the NCLEX or your ATI, what you've learned is what the ECPI School of Nursing is using for our, what we have given you in the past. But remember, there may be some variations. Don't let that get you too concerned, because usually the questions they're going to ask you are going to be, it's not going to be specifically right the best answer for those. They're going to give you ranges, so you'll have a range that you can go through. So if you're seeing, for instance, they're not going to ask you what is the blood glucose if you've got too much sugar. They're going to give you a scenario, and then you just have to kind of know, here's my lab value, so I need to figure out this is what I see in my patient, and so it's most likely going to be elevated. All right, but you're doing well. All right. All right, we're ready for serum electrolytes. Let's take a look. Hypokalemia, what you going to assess for?
Shavok. Oh, never mind. I thought it was hypocalcemia.
Okay. All right.
Arrhythmia.
There you go. Cardiac, you're going to assess for cardiac arrhythmias. Okay, and then I've given you some more information here. So assess for hypokalemia for patients taking this cardiac medication.
Digoxin.
Oh, yes. Common question. All right. Yeah, Dig. Okay. And then, of course, just a little bit more about hypokalemia. Okay. Remember that alkalosis, if a patient's in an alkalotic state, they're going to move potassium into the cells, and it's going to cause your hypokalemia. All right. So this is just something for you to work on at home. This is your clinical time. And I've given you some information here. So I'm asking you, what is the problem? Why should the pulse rate be monitored? And what may be the cause of the problem? So think through that. Okay. Here's hyperkalemia. You can see what we're going to monitor for, but what are we going to avoid? What kind of diuretic? If we can.
Loop.
Okay. All right. Potassium saving diuretic. We're going to avoid those diuretics. Why? Why would we want to not have a thiazide here?
Oh, because we're getting rid of what? I'm kind of confused.
Okay, if they
Because
already have high
too much potassium, then we want to get rid of it.
Right. So hyperkalemia, they already have a high level of potassium, so we might give them something else.
So we want to give them. So we want to avoid the potassium-saving diuretics.
Yeah, or the potassium. Yeah, very good. The potassium-sparing diuretic. We've probably heard that term. And of course, anything with potassium in it, salt supplements or salt substitutes or potassium supplements for hyperkalemia. And this just gives you some little information. All right. You don't have to memorize everything about every condition, but just some of these just really clear, succinct little things will help you get through. So here we have hyponatremia. You're going to monitor fluid. What and what?
What, eyes and nose?
Okay, losses and gains. There you go. All right. And some of our GI symptoms. Let's take a look at those GI symptoms. Anorexia, nausea, vomiting, and abdominal cramping are the symptoms you want to look for. For central nervous system symptoms with hyponatremia, these are the ones that you might want to know. Of course, we're going to check gravity, specific gravity, those types of things. Remember, water is hypotonic, right? So we have to be careful giving lots of extra water, particularly if they're isotonic, because it's going to drop them. Too much water can cause them to be hyponatremic. All right, and of course, seizures. So a quick, what I call in a little nutshell, hyponatremia. Hypernatremia, loss and gains, very similar to what we just did. And then, of course, we're going to monitor for, of course, if you're going to have too much salt, it makes you thirsty, temperature can go up. Sometimes, if it gets really bad, of course, you're going to have some disorientation. All right. Hypocalcemia, I'll be sure to watch for seizure precautions and hypocalcemia. Make sure the airway is okay. All right. All right. So we're going to monitor for a few things. Can you think of what we might monitor for hypocalcemia?
Weakness.
Okay, let's see. Yeah, tetany. The biggest thing here is for hypocalcemia is the tetany. Tingling sensations, of course. Remember, think about an alcoholic. They come into the emergency room. You're going to take that blood pressure. And somebody mentioned it earlier. I don't know which student did. Talked about Chefkoff's sign and the Trousseau sign. Tapping the cheek causes spasms. Okay. If you have the blood pressure, you put it on for a couple of minutes, and it's going to cause those tetanic reactions. So hypocalcemia, definitely want to watch for seizures. Make sure you do the airway and be sure that you're testing for tetany or tingling sensations. What's going to happen on the EKG? Remember, this is no calcium or very low calcium.
Arrhythmia.
Yeah. You're going to look for this. You're going to see a long QT interval because calcium is needed to make muscles move, make electrical conduction. So that's what you're going to be seeing. All right. Hypercalcemia has got too much. Of course, you're always thinking about the heart when you're thinking about calcium. You're going to do the rate and rhythm. Remember, with hypercalcemia, we can become digitoxic if the patient is on digitalis. Right? We want them to mobilize. We want them to work. We need to let them get moving. And of course, oral intake is important. So hypomagnesemia, again, you could have some digitoxicity with this as well. And we're going to take seizure precautions with not enough magnesium. Okay. That's why sometimes when we have homeless people as patients or alcoholics, we're really looking at these electrolytes because, when they're low like this, because they're not eating properly and not getting the nutrition substance that they need. All right. For hypermagnesemia, watch for that hypotension. All right. Check those deep tendon reflexes. And of course, we're not going to give them any magnesium containing medications if we can help it. There's your hypochloremia. The causes of that, of course, suctioning, vomiting, kidney disease, and heart failure. Remember, alkalosis. Hyper, monitor for acidosis. Hypophosphatemia, you're going to monitor for these things. All right. Hyperphosphatemia, I just put the most important things on here. So I think if you know these and understand these, you should be able to answer most questions related to electrolytes. Signs of tetany. Why? Well, okay, here's the question. If we have too much phosphorus or phosphate in our bloodstream, why are we going to look for tetany?
Lowers calcium levels.
Yes, there's an inverse relationship between phosphorus and calcium. If you have, in this case, a high phosphorus level, you're going to have a low calcium. We just talked about low calcium, hypocalcemia, which means we're going to now have some tingling and numbness. We're going to have some of that tetany. You're going to have maybe some positive Trousseau signs or checked off signs. Yes, so those two are, phosphorus and calcium are connected. All right, let's look at some coagulation studies. Basically the same thing here as PTT. What do you think? Can you remember the usual PTT range?
30 to 40.
Okay. All right. 60 to 70s actually. Therapeutic range is usually 1.5 to 2.5. We use it with heparin. APTT, I'll give you this, that's 30 to 40. Okay. Now you have your prothrombin time here. We use the PT for warfarin or Coumadin. And the international normalized ratio, we will use this to monitor warfarin levels. And it's generally reported with the PT.
Okay, so if I could ask a question.
Sure.
I'm sorry. So this is like in seconds, right? Like how long it takes.
Oh, yes.
to-
I'm sorry. I didn't. Yeah. I'm
Okay.
sorry. I didn't. And certainly not 60 minutes, right?
Oh, yeah. Okay. So like the PTT is 60 to 70 seconds. It takes to clot and then.
Same here, 30 to 40 seconds. Yeah.
Okay. Just to make sure. Thank you so much.
Oh, no, I should have done that. I just kind of forgot it.
Okay.
I'm so used to not saying seconds, to be honest with you. I kind of forgot.
Okay.
Yeah. Yeah. All right. I made an assumption and I probably shouldn't have. Okay. All right. How about CBC? There's lots of things on the CBC. I'm going to give you that. But basically what it means is that there's a total of the whites, the red blood cells, platelets, and the H&H, which is hemoglobin and hematocrit. For the male, is the hematocrit higher or lower?
It's higher.
Mm-hmm. Yes. And remember that hematocrit is in percentages. It's percentage. And it's definitely higher because females tend to have a lower one. For hemoglobin, the same. All right, a little bit lower. What's platelets?
150 to 400.
Perfect. All right. And of course, everybody knows whites, right?
5 to 10.
Yeah. Good. All right. Let's look at some diagnostics and formulas now that might be of interest. We should all know this, ABGs, and y'all had to really have studied hard on those ABGs. So pH?
7.5 to 7.45.
Perfect. How about the PCO2?
PCO2 is 22 to 26, isn't it? 35.
35 to 45. Yeah. You're
And
thinking
the-
of bicarb.
Yeah, 22 to 26.
Yeah, there you go. That's bicarb. And the PO2, of course. There's a difference between the pulse ox and the PO2.
80 to 100,
Okay.
80, above 80.
You got it, 80 to 100. And then oxygen saturation, we like to see it at what?
I need to.
Above 94.
Yeah, 95 to 100 is pretty much norm. All right, so these are important to know. All right, here we go. What's the name of this first one? There's no compensation here. Don't worry about that part, just the 4 states. What's the first one? What kind of metabolic, respiratory, what?
Respiratory.
Has it been a while?
You got us, Professor Stevenson.
That's okay. It's okay. Let's take a look. Respiratory acidosis. Why is it acidotic?
Because pH and the CO2 are in an acidic state.
Yeah, that's kind of low there. How about this next one? So now that your mind is back on ABGs, all right. So you have a increase in bicarb. All right.
Metabolic alkalosis.
Excellent. How about this one?
Is that
Respiratory alkalosis.
Okay. Respiratory alkalosis. Obviously, this is above the 7.45. Okay, definitely. This patient's in trouble. How about this one here?
Metabolic acidosis.
Yeah, metabolic acidosis. And you're familiar with the ABGs. Just a matter of kind of bringing some of this material back. You might get a couple of those sometime on these exams. Okay, ABG is important. Don't forget your Glasgow Coma Scale. All right, I put it here for you. There's no questions related to that, but just so you know, this is what we look at: the eye opening, the verbal response, and the motor response. A very common scale that we use. All right, your ABCs of skin assessment. All right. Now, are you ready to recognize some rhythms? Everybody ready? Now, what we're not going to do with these rhythms, you're not going to count the blocks, all right? You're not going to count blocks. Generally, even on NCLEX, you're not going to have to go through that detailed analysis that you've done before, but you need to know, what are you going to do if you see this strip? What nursing actions are you going to do? That's really what they want to know. Okay, let's do it. Anyone? Oh, y'all know this one. Come on, come on. Be brave.
Sinus bradycardia.
All right, let's take a look. Whoops, wait a minute. Yeah, sinus bradycardia. Sinus bradycardia. All right. So if you just looked at this and go, whoo, you know, even if you couldn't remember how to count your boxes, you go, wow, that's slow. That person is in trouble. It's probably below that 60 mark, right? So what am I going to do? What kind of signs and symptoms am I going to see in my patient if their heart ain't beating too well? That's what you think as a nurse. All right, so sinus brady. What's this one?
AFib.
All right. Whoops. Ventricular fibrillation. Okay. What's happening in this one? What's the heart look like? What's going on?
The ventricles are freaking out.
Aren't they? You think they're going to have very good perfusion?
No perfusion.
Like Jello.
Shock them.
Yeah, it's going to be like a can of worms, you know, wiggly. All right. And these are ventricles. That's a very serious problem, because then the body's not going to get that blood that it needs. It's bad enough to have AFib, but it's even life-threatening to have this. Okay. All right. Let's look at another one. What is this?
It's super.
Sinus tachycardia.
Yes, it's sinus tachycardia. Now, do you see P waves in there?
Yeah.
Yeah.
Right. So with sinus tachycardia, it's moving really fast, but you are going to see the P waves are still present. Okay. So you can just look at this strip. You go, whoa, it's speeding up pretty fast here. So what is my patient going to be looking like? All right. All right. What's going to be manifested? And then what am I going to do to help that patient? Oh, all right, let's try this one. What do you see with the PR intervals?
The first degree.
Absolutely. That PR interval is kind of elongated, isn't it? Right? So it is a first degree heart block.
So does it matter if the T wave is huge like that?
Not at this point.
All right.
It's just the way the EKG read it. Yeah, they're okay. The thing is, I want to just kind of remind you, what's going on with the first degree heart block? Do you remember?
Something's irritated and it's not getting, like, between the sinus node and the atrial, or yeah, the sinus node and the atrial node, it's not getting there fast enough.
Right. So definitely, is this rhythm, is the rhythm regular? Yeah,
Yeah.
it's regular rhythm. Yeah. Patient could probably survive with this, right? All right. Let's look at the next one.
So is it a Winky Bach?
Oh, it is a Winky Bach. All right. What kind of Mobitz? What's it called? Mobitz type what?
Oh, it's 1.
All right. So what's the other name for this?
Sorry, isn't it Mobitz?
You got that. You said Mobitz type 1 Winky Bach. But what would we call it? What
Oh,
kind
second degree heart block.
Yeah, we would call this the second degree AV block. But notice the progressive lengthening of the PR interval. Notice it gets longer and longer until all of a sudden what happens? What's missing?
It drops the PR interval.
It drops the QRS.
QRS, I meant, yeah.
Yeah, see, and here we don't have one. So that's how you can recognize that one. Okay. All right. This one can rapidly progress to a complete heart block. What is this?
This is a Mobitz type 2, isn't it? Because the PRs are the same.
Okay. Second degree. Mm-hmm. Yep. Very good.
Why couldn't have our EKG test been like this?
Because you had to do all the box counting, right? And believe it or not, you learned a lot from that EKG test because you do remember these. Just now a matter of review.
Can I get my grade bumped up then?
Sorry. No. All right. So you might get a strip or two on your exam. Okay. On your exams. Okay, what's this one?
Third degree heart block.
Yeah. What's wrong with this? Note the PR intervals. They're different, aren't they? Everyone is different. Whoop, that's different. Okay, look at that one. Oh, that's really strange here. All right. There is absolutely no relationship to the QRS complex. That's why we know it's a complete heart block. This patient is going to need a heart or something else, right? All right, third degree. All right, let's look at this one. This is supraventricular tachycardia, but I want you to notice something. See how narrow the QRSs are? Beep, beep, beep. See how tiny they are? What this is saying to us is the atriums are moving very, very fast. It's above the bundle branches and above the ventricles. That's why we call this a supraventricular tachycardia. All right. What kind of signs and symptoms might you see with that?
What do you mean, signs and symptoms in the person?
Yeah, I mean, what could you see something with the patient if you saw this or hear them say anything? How would they be feeling?
Like heart palpitations?
They could possibly feel that. I don't, in this case, there's really not a lot of palpitations going on, but that atrium are beating so fast, they're going to feel like their heart's just going really fast, right? They might become anxious, which only will increase the problem, right? They could possibly have some problems with some breathing because of the fast, it's going way too fast. But there are a lot of people that have this and they seem to do okay with it. All right. But we need to slow that heart rate down, obviously. Because what we don't want to have happen if this patient keeps doing this, that those ventricles could get really confused and they could actually start speeding up, right, which could cause even more problems with them. All right, we need to slow it down. All right, what's this little squiggly stuff.
Is this AFib?
Yes, that's AFib. Where's your P waves?
There aren't any.
There aren't any. Is this regular or irregular?
Irregular.
Yeah. Yeah. Yes. This is can be also very dangerous if you have ventricles that begin to react to this, and they will eventually, in many cases. Sometimes the ventricles become so sensitive, they're actually going to start going really, really, really fast and going to have what we call rapid ventricular response, RVR, where your blood pressure shoots up to 160 over something, and then the heart rate is extremely fast because the AFib is just going so fast and so squiggly. The ventricles are trying to get organized and trying to get the blood pumped, and they don't like this at all. Okay. All right. Sometimes with this particular medication, with this particular problem, because especially if a patient has had RVR before or rapid ventricular response, sometimes they might give them like metoprolol to kind of settle down some of those excitable nerves in the atrium, but they might also give them flecainide, which is an antiarrhythmic, because it decreases the speed of the ventricles. So it doesn't happen to cause that RVR. All right. All right, good. All right, what we got here?
Sawtooth.
All right, it's a flutter. There are multiple P waves, huh? Little sawtooth P waves. Yeah, okay. A flutter. We know that's ventricular tachycardia. What's wrong with this? What's missing?
Everything.
Yeah, the QRS is kind of bizarre, right? It's missing the P waves. We don't see that. What could happen if somebody is in this particular rhythm? What could happen next?
Pulseless.
Okay, it could be two things, right? All right. So what happens if we don't treat this? Remember, the ventricles are speeding like, they're right. The ventricles are working. It can go into ventricular what? Fibrillation and death. So we need to slow this down, definitely. Okay. All right. Question for you. You have a 54-year-old male who's in the emergency room with chest pain and nausea. The patient is diaphoretic and appears very uncomfortable. The nurse is taking his initial vitals, and when he suddenly becomes unresponsive and you see this on the monitor, what are you going to do? Are you going to check the pulse, intubate the client, start CPR, or are you going to defibrillate?
Check the pulse.
Why?
Because if he doesn't have a pulse, that's when you shock him.
Okay. Are we going to shock without a pulse?
No.
What are we going to
Wait.
do?
That's how you do shock without. If he's in VTAC.
Okay. So we're going to start CPR, right? We got to do some CPR. We got to do some stuff here, right?
Yeah.
Yeah. Okay, we got to do something fast. Yes, but we have to make sure we're checking for a pulse. If we don't check for that pulse, what could happen? What's going to happen? That patient's going to say, "What are you squishing me for?" Right? All right. Unfortunately, this patient is unresponsive. We don't want to do any type of CPR or something if the patient has got a pulse. Right? Okay, we're just going to shock him now. Okay. All right. Good job. All right. What's this one? Yeah, ventricular fibrillation. What are we going to do immediately?
Defib?
Yeah, we're going to immediately defib this person because this will lead to death. All right. Because remember, in this case, the ventricles are not speeding. They're speeding terribly, but they are wiggling like worms. And there's no way the blood is going to be pumped through the grade aorta out to the body if the ventricles are sloshing around and going all kind, like just doing all kinds of strange things. So the patient's going to die. All right, we have to defibrillate. All right. All right, what's happening to this patient? What should you do before taking any further action? What's happening?
Oh, you give CPR.
Yeah. What is this?
VFib.
Okay, it's VFib, and then what here? What's happening here?
Asystole.
Yeah. All right, if it's VFib, we got to see what we're going to do with that patient. And then, of course, once we get to this line here, shocking's not going to do much. There's no electrical current to shock. Okay, good. So here is just a couple things to look at. These are PACs, some things that can cause that. You can see the little premature atrial contractions. And so I want you to think about what kind of patient education would be appropriate for this patient. Okay. Here's a nice PVC, premature ventricular contraction. Y'all recognize that? So let's look at something else. What's the term we use to describe two PVCs in a row?
Couplets.
Okay. So what occurs when every other complex is a PVC? What's its name? Bigeminy, of course, two. And what's the one that's called third?
Trigeminy.
Yeah. Yeah, okay. Too much alcohol can cause this as well. Did y'all know that? Absolutely. All right, good job on those strips. It's 10:29. I don't see Dr. Wheeling yet. So we're going to go on and continue on here.
I'm here.
Oh, I'm Dr. Wheeling. Let me finish this real quick. I'm almost at the end.
Take your time.
Okay, here we got some OB, just to let you know a little bit about OB and PEDS. Again, I won't be reading all this to you. This is a common type of question that we might see, or something, the concept as placenta previa. This is just gives you some quick overview of what that means. Sterilization for male and female. It's important to kind of review. Mastitis. How are you going to take care of someone with mastitis? And there gives you all these suggestions. And notice that it's really caused by staph organism. That looks very painful. A couple of things about pudendal nerve blocks. All right. So I've given that information to you here. All right. You be sure you review your fetal heart rates. All right. So if it's a variable, what's causing the fetal heart rate strips to change? Well, you're going to have some cord compression. What are you going to do? You're going to move the patient. Okay. So this is something you might want to just review back from your OB. APGAR scoring is another one that's very common. So this gives you some information on APGAR scoring and an example. Rotavirus also is a pretty common concept. How do you test a preschooler's visual acuity? And this is like our little Snellen test, but a little bit different for a preschooler. Here's a medication to treat cystic fibrosis. How to treat overdoses. Okay. These are just all the how to treat overdoses. So I'm just going to leave that with you there. All right, and of course lead, and then just some you can enter in if you want to how to prevent poisoning. You can just fill that in if you like. Okay. Oh, I put it down. I forgot I gave you the answers. Okay. All right, rheumatic fever. Just be sure that you're reviewing that. All right. Intracranial pressure, again, talking about especially for children and infants. What should you do? All right, and this is the things that you would want to do. These are very important concepts for for infants and all of that. So just be sure you kind of review that if you're not remembering some of that, especially that phototherapy. Okay. And some more important concepts. Community health, about your windshield surveys. Just some things specifically for you to take a look at. What do you see lacking? What are your potential problems? How to interpret a Mento test. Whoops, there it is. All right, so this is the end. So you spent $12,000 on probably Starbucks. And so maybe you'll be finished NCLEX pretty soon. So good luck on your ATI predictor. Don't forget there's the pharmacology still has a lot of other activities for you to work through. And I had to speed through this pretty fast. Well, Dr. Simmons, it's so nice to have you here today. They're all excited about Med-Surg.
Oh, sure. Do they need a break?
Yeah, we haven't had a break.
Okay.
Okay.
Yeah, you can go ahead and take a break. Is 7 minutes good? Do you guys want to come back at 10:40? Or I don't know how long you normally give them.
Usually it's 10 minutes, but 7 minutes or so is whatever you feel.
What's about 10:35? They can come back at 10:45. That's fine.
And Professor Stevenson,
Yes.
you are gonna upload this.
I am. While you're discussing Med-Surg, I'll go ahead and upload it for you.
Okay,
But
thank you so much.
yeah, of course. The Med-Surg is already uploaded, Dr. Simmons.
Yes, thank you.
Mm-hmm. All right. And when you're all finished with them, they can go. I told them I would see them next week for their ATIs.
Okay, and what is next week? Med-Surg?
Med-Surg followed by pharmacology.
And Pharm. Okay.
Yeah. Med-Surg and pharmacology.
And then their predictor is the following week?
Yeah, actually their comprehensive is in week 7. Mm-hmm.
7, okay.
So next week is week 6, so the following week is their comprehensive. That's why I went ahead and did some quick review on the comprehensive.
Yeah, absolutely.
Yeah.
And then do they take a second comp?
They do. A week later, it's going to be on the 16th of June. Is number 2. And the second one, the first one is 6/2.
Okay.
So yeah, A and B. And if need be, if they have to take that third one, it's on June the 23rd.
Okay.
Mm-hmm. Yeah, this has been the fastest 5 weeks ever.
Has gone very fast. Yes.
Absolutely.
Even in the other cohort, moving lightning speed.
Oh, definitely moving fast. All right, so I'm going to upload the comprehensive predictor for them review. Okay.
I'll be ready to go in at 10:45.
Okay, that's fine. That's fine.
Okay. All right, let's go ahead and get started. I know you all missed Med-Surg content terribly, but the good news is we get to go through it today. So a couple things. First, you all have been away from Med-Surg now for an entire quarter, almost a quarter and a half. Third quarter is very much specialty. So we've got to start getting back in the mindset of Med-Surg and going back to the basics of answering these questions. Your Med-Surg ATI is next Wednesday, I believe Professor Stevenson said. So what I would like for you to do is each day do one of the targeted Med-Surg quizzes. You remember there's one for cardiac, there's one for respiratory. So between now and next Wednesday, if you do one each day, you should be able to make it through all of them. There's another area on ATI where you can do Med-Surg questions. So you've got the targeted quizzes. And then if you go under, I think it's Learning Systems 3.0 or Learning Systems 2.0, there's another quizzing section. And I think it's a completely different database of questions. And you can pick by category. So if you know you're super weak in cardiac, you could hone in on that. You could pick them all so that you're getting just everything Med-Surg. And that, at this point, is the best way to study. You can't really go back and be looking at PowerPoints and reading in the book. It's going to be doing practice questions. I hold a Med-Surg intervention group every Thursday at 1 o'clock. Would anybody be interested in coming to that? So obviously it's for quarter 2 students because they're in Med-Surg, but this week we are going to be discussing some of the cardiac and respiratory. The next Thursday would be after. So is there any interest in attending that? It's for 1 hour.
There is, Kendrick and I are disposed this Thursday for some SNA stuff. Would it be able to be recorded?
Oh yes, I always record it.
Okay.
So what I can do, because you guys aren't members of that group, I'll send it in an email. I just worry, I don't know if you'll be able to see the recording that way. How about this? The people who want to attend, but maybe who can't, email me and I'll add you as a member of the group. Then you should be able to go back and review it. If you're going to be there live Thursday, you should have access to it. Always record it. And what we typically will do is I go over some of the heavily missed content from the exam, and then we do practice questions. And so for some of you, I think it would be helpful in getting back to the basics of answering these questions, right? So what I did for this is I basically remediated for your cohort based off of the results that you all had as a cohort on the first Med-Surg ATI that you took. So any question where less than half of you answered correctly, that is the information that I have included. So obviously this is not all inclusive. This is very select for the topics that were most missed. All right. So the first one was regarding stroke. And so let's just look at the title of it. You're caring for a client with left-sided hemiplegia. What do you already know about this patient? Just based off of that information.
Right-sided stroke.
The stroke or the lesion, remember we call them lesions, obstruction, whatever it may have been, was on the right side. So what do we know about hemiplegia?
You will be ignoring the affected side, so we need to constantly remind them.
Correct. So remember, when they lose sensation and movement on half of the body, they tend to develop lack of awareness of that side. And so this can be dangerous because let's say you're moving a patient into a wheelchair. And if the person who's going to be pushing the patient isn't being mindful of that, if they cannot move their left arm and left leg, now you potentially have a foot not on a footrest. That could be dragging, causing injury. The left arm may be hanging off of the wheelchair, and now you're going through a door frame. And so there's potential for damaging that. So we really want to be aware that the patient is likely to develop a lack of awareness of that left side of the body. And then it would be flip-flop. If it was a left-sided lesion, we're going to potentially see hemiplegia on the right side. So we're always observing for any signs of injury, and that could be secondary to neglect. When they cannot control the arm, when they don't have movement, they tend to develop shoulder soreness. And so sometimes that arm needs to be supported in a sling. When you put them in the wheelchair, what we would want to instruct them to do is using their strong side, which would be the right side, take the left arm and actually put it into a good position. Or you can even prop it up with like a pillow up underneath it so it's supporting it. The other thing to keep in mind, anytime somebody has an issue like that, and let's say you're going to help them get from the bed to the wheelchair, do not pull on the affected arm. And any UAP would have to be instructed in that as well. You cannot pull on the affected side, so we have to transfer them safely. And then that side of the body needs to be protected because the patient loses awareness that it's even there. So remember, we're always trying to encourage independence. We want patients completing as much of their ADLs as possible so that they would, when they're dressing, they want to dress the affected side first because they're going to have to put that arm into the sleeve of the shirt. They have to still provide care for that half of the body. They want to make sure that they are utilizing their strong arm in order to make sure that that left foot is on the footrest, that the left arm has been brought more midline and protected. And they need to be taught in scanning. They've got to turn their head and they need to be mindful and looking at that side of the body. So always go back to whatever they're giving you in the question and recall the information before you ever look at those responses. And what do you remember about this? What comes to mind? Because that's going to help you identify what are going to be our nursing priorities. There was another one regarding diabetes mellitus, and you've got a patient who's going to be having a scan, and the scan has been ordered with contrast. So there's several things that we worry about with contrast. What are some of those in any individual, really?
Allergies.
Allergies.
And
Medication.
what is one of those allergies that we think about?
Iodine, shellfish.
Yep, iodine, shellfish allergy could have a cross reaction. So we're assessing for that. What else about contrast?
We need to know renal function because it's CT contrast is excreted through the kidneys.
Absolutely.
So if they have decreased renal function, we need to reconsider.
Correct. So you may need to call the provider and say, this is what the patient's latest lab work is, this is what their creatinine is, their kidney function tests, and they may decide not to do it with contrast. A patient with a kidney injury or elevated kidney function, it can put them into kidney failure to have contrast done. So we have to make sure that it's the right candidate for that. Even though it's been ordered, we have to be reviewing that and making sure that it's safe. So for patients with diabetes, we have to look at their med list. And if they are taking metformin, which is a common oral hypoglycemic agent, they need to withhold that for up to 48 hours. So metformin, when taken with a contrast media, can cause hypoglycemia or lactic acidosis. And it can also put the patient into acute kidney injury. So that's another element that's particular for a patient with diabetes mellitus that you have to watch for. Peritoneal dialysis. What do you remember about that? Don't look at the information on the screen. Just what do you remember about PD?
It could be done at home.
Okay, it can be done at home.
It uses the peritoneum to like filter the blanking out.
No, that's right. They're using the peritoneal membrane as the filter because remember your kidneys are your blood's filter. That is your copy. And if that is broken, you're not going to be filtering. So they use peritoneal membrane. So what does that process look like?
Well, you do it at night and it's like several rounds, isn't it?
Mhm. So there can be several exchanges. It can be done at night. A lot of patients choose to do it at night. The machine will change the dialysate for them so that it can go over the whole time period that they're sleeping. It can be done during the day as well. What else? How do we do it?
Mostly works through a gravity mechanism.
Right, so the dialysate bag is hung higher than the patient's abdomen, and by gravity, the dialysate will infuse into the belly by means of what? How does it get into the belly so that the peritoneal membrane can do its job? What has to be inserted?
Shunt before.
It's a catheter. It's a catheter that stays in the abdomen, right? So that's going to be inserted, and then they hook up the dialysate to that. Gravity drains in. Then they're going to have a prescribed dwell time. So they let the dialysate sit in the abdomen for a certain period of time. This is where the filtering's taking place. And then what do we do? Bag up high, gravity drained into the belly, dwell time. Now what do we do?
It comes out somehow.
How?
Do we have to program it?
Do you have to program it? No, not necessarily. So the bag needs to now go, remember, by gravity, lower than the abdomen, and then the dialysate will drain out. So if a patient, let me back up. What's one of the #1 complications we're worried about with PD?
Peritonitis.
Infection, which would be or result in peritonitis. So what do you know that we look for when a patient should develop peritonitis? What are going to be some of those key indicators?
Rigid, board-like abdomen.
Yes, and that is the classic description of peritonitis. You'll probably see it verbatim somewhere. It's rigid, board-like abdomen. It's an involuntary contraction mechanism secondary to that peritoneal membrane being inflamed. What else do we know about infections? What do we look for when somebody has an infection?
White blood cell count.
Okay, potentially elevated WBC.
Fever, exudate.
Area.
Yep, so you can have fever, you can get redness to the area. They may start to have an exudate. What does that exudate typically look like?
Cloudy, white, maybe yellowish.
Correct. So we call that a purulent drainage, right? So you got a patient with PD. We know that the main complication that we look for is infection, particularly the development of peritonitis. So what are those signs going to look like? Well, the effluent, the fluid that has now dwelled in the abdomen that needs to drain out, may appear very cloudy or opaque. That is typically the first thing we're going to see. We need to monitor for signs of an infection. You just named a bunch of those: fever, purulent drainage, redness, the dialysate looking cloudy or discolored, and then that rigid abdomen. So it's critical that when you see your question, just recall, you guys know this information. You may not remember everything about the topic, but a lot of it you do. And then if you can just bring that information to the forefront, when you look at the question, you're really going to be able to identify it because you know it. Don't let the responses lead you in the wrong direction. Go ahead.
There was a question, something about the comparison between the peritoneal and the other dialysis and the protein. I was wondering if you can go over that. Which one is depleting protein more?
Depleting protein more, I would think would be peritoneal dialysis, but I would need to look.
Okay. Thank you.
So what is our main, what are the things we look for with hemodialysis? What's our biggest complications that we look for?
Infection?
It can get infected, but usually not the number one complication. Does anyone remember what that is?
Does it have something to do with the pump?
Not the pump.
No.
Blood pressure.
The infiltration?
So we do have to monitor the patient's blood pressure. So through hemodialysis, that is something that is very important, because when we're drawing off that extra fluid while cleansing the blood, it can cause a patient to become hypovolemic. And so we would see drop in blood pressure. So that is something that we look at. So I'm glad you brought that up. So what is something that we might want to hold until after the patient has hemodialysis?
Lasix.
Potentially they're diuretic because it's getting ready to get pulled off through the machine. What about blood pressure medication? You give them blood pressure medication before hemodialysis, they have the extra fluid drawn off. There's the potential for them to become hypotensive. So that's something that we would typically hold until after they return from hemodialysis. We reassess and then get administered the medication. So biggest complication with hemodialysis is failure of the graft. And we're going to go over how to check for that here in just a couple minutes. This is a topic here, and these kind of don't go in any particular order. It was the order they were on the ATI report. For whatever reason, they always ask about genital herpes. So why do you think that that's an important topic regarding teaching our clients? What do you remember about it? Why is it important? And don't look at the information on the slides. I just want you to recall what you know.
I'm sorry, can you repeat it one more time?
So why do you think genital herpes is a topic that is very important regarding our client education? What is important about it that we have to make this a very important teaching opportunity?
They need to know like when they can give it to other people. Also, like when you're pregnant, you can pass it on to your baby.
Right. Okay, so what else do you remember about genital herpes?
That it could still be passed even if it's not like an active outbreak.
Yes. And so that's really a key indicator, is because some individuals will think that only in the presence of lesions are they contagious, and that's not the case. What else about a patient who maybe does have, let's say they have genital herpes, what else is important for them to know just as it pertains to themselves?
Hand washing.
Hand washing.
Why is that important?
Because it, like if you're touching it or applying medication or whatever, now that's on your hands. So then you go touch stuff.
Yeah, they can, well, one, they can give it to themselves in other areas.
Yes, that's called self-inoculation, and that is possible. So even, this is the topic was regarding genital herpes. It's the same virus if it's oral. So patients who have cold sores, we call them, right? A lot of times they're very itchy. And so patients are scratching, and then you're very likely to touch the rest of your face, to touch your eye, and you can transmit it elsewhere on your own body, and you can pass it to other people. So that is another key indicator that people may not really realize. So it is transmitted by direct contact. So in the presence of a lesion or an outbreak, that is when they should abstain from direct contact, whether that's sexual intercourse, touching the lesions in any way. So we call them cold sores typically when they're orally, because when a patient gets sick, their immune system is being taxed. And so when the immune system gets taxed, the virus seizes that opportunity to reemerge. I've known several people who got the COVID vaccine and subsequently had an outbreak because their immune system was working at building antibodies. So very similar to catching a cold or being ill. Sun exposure, that's another way that we see this virus reemerging. And it is possible that they get it in other areas of their own body, as well as transmit it to family members or other people in close contact. The very important part of it is that you can be contagious with no symptoms. And I don't know the latest statistics. It used to be over 90% of people with herpes never had an outbreak. But that doesn't mean they don't have the virus, and it doesn't mean they're not contagious. And so that's why 1 in 4, 1 in 3 people have it. It gets passed very easily because somebody may not know they even have it if they're never tested for it. So we want to encourage them to still use barrier methods when they are engaging in sexual activity, because even though you don't have an outbreak, there's something called viral shedding that can occur. And so it's still shedding viral pieces on the surface of the skin, which can cause transmission of the disease. If somebody does have genital herpes, they should divulge that information to any of their partners so that they know there's always a risk, even in not in the presence of an active lesion. You brought up a good point about it being important during delivery, vaginal delivery of a baby. So they will typically assess the mom to see if there is any evidence of infection, and they may opt to just perform a C-section so that the baby doesn't go through the birth canal and possibly get exposed to it. So it can cause ocular issues. If it gets in the eye, it can lead to blindness. Remember, there's an encephalitis that's brought on by herpes simplex, so it can cause significant problems. So sometimes they will just opt to deliver the baby by C-section. There's medications, antiviral medications that should be started very soon after what's called a prodromal symptom. This goes all the way back to patho. What are prodromal symptoms?
Something's happening, but you're not sure what it is just yet, but
Tingling.
Yeah, you're feeling something's not right. It could be before a flu. You know, you're just not feeling well, but you can't really pinpoint what it is. And so with this particular disease, they do tend to feel tingling, itching, sensitivity, because remember, this virus lives at the base of the nerve. And so that's why it reemerges typically very similarly like what we see with shingles. So it's usually in a very close proximity to the area of where the disease was contracted. So they can feel like some sensitivity as that nerve is being stimulated. So if they start to feel that, that's when they really want to start their antiviral medication. They should not be wearing any sort of undergarments that don't breathe. So cotton undergarments do allow good air exchange. They shouldn't be putting any sort of occlusive ointments on the lesions. They shouldn't take strong bubble baths with like that perfumed soap. All of that can be further irritating. Hand hygiene is critical. So if they are, like a lot of times for cold sores, there's over the counter like Abreva. And so sometimes they are applying a little bit of this lotion. They need to immediately wash their hands. The lesions themselves, so if they are genital, they can still be washed in the shower, and they should be, because we don't want a patient getting a secondary bacterial infection, but mild soap. And then after they get out of the shower, they wouldn't want to use a towel and like vigorously rub the area, because it can disrupt and further irritate the lesion. So just gentle, nice patting motions so that they do get dry. And then just comfortable, loose clothing, nothing tight fitting, none of that synthetic stuff. Polyester underwear is a no-go for this, or anybody who's prone to any sort of like genital infections. Eating well will help, a well-balanced diet, making sure that they get adequate fluids. A lot of people during outbreaks of herpes simplex and shingles get extremely tired. So we want to make sure that they are getting adequate rest, because their body is fighting a viral infection at the time. So just to take care of themselves and make sure that they're being safe. So the next topic is hepatitis and cirrhosis. And then it says priority finding to report. So this is something you have got to get back in the mindset of. When you have a patient who has had a procedure, who's had a surgery, or has a medical diagnosis, there are going to be certain manifestations that are expected findings for that patient. So there's going to be expected findings for a patient with hepatitis and cirrhosis. This is asking you to identify what we have to report to the provider. So if you call the provider and you say, hi, Mr. Smith in room 302 has liver failure, and this is the second day that he's showing signs of ascites. It's really an expected finding that end-stage liver failure is going to show some fluid in the abdomen, right? Not necessarily enough that we need to make a phone call and alert them over unless it's causing a complication. You could have a patient with pneumonia and their O2 sats are 92. That would be an expected finding for somebody who's just diagnosed with pneumonia and we're just starting their treatment. So what do you remember about hepatitis and cirrhosis that we would need to be mindful of? What do you remember about this topic? And maybe it's just expected. Maybe you remember some expected finding things like we would expect to see in these patients.
Jaundice.
Okay, they could show signs of jaundice. What else?
Asterixis.
So asterixis is a sign of what? Is it a sign of liver failure? Or is it a sign of a complication of liver failure?
A complication.
And what is it a sign of? What is being affected if a patient shows signs of asterixis? Is it the liver?
Yes.
So we have asterixis secondary to the liver. Anyone have anything to elaborate on that?
Isn't it like tremors?
Asterixis, just to remind you all, that's when you have a patient, I think you guys can see me, when you have them extend their hands, they will do an involuntary flap. I think I have a video here just to remind you. But this is a sign of something. So ascites, we would expect in a patient, they've got liver failure. So let's look at this guy. See how his hands are flopping? He's not doing that on purpose. If you bend your wrists back, you can probably hold them fairly still. So what is causing that? What organ is being affected?
The liver?
Yeah.
The liver is causing a problem and now the brain is being affected. That is a complication. So you can have somebody in liver failure, we would expect their liver functions to be off. They can be definitely holding fluids. Their lab values could be off. But if we start noticing asterixis, decreased LOC, that is a sign that now not only is our patient with hepatitis and cirrhosis having the normal expected findings, now we're noticing what's called encephalopathy. Now the brain's being affected. What causes that with liver failure? What
high levels of ammonia?
Yes, it's elevated ammonia levels. And so then they can start showing signs of encephalopathy. If you see that word, that means the brain is now affected. So you can have patients in liver failure with no brain involvement. That lets us know something is getting worse rather than an expected finding. It would be like you have a patient with COPD and you call the provider to let them know they have clubbing of the fingers. Or you call them to say that they are showing signs of a barrel chest. We wouldn't do that because that's a normal finding for somebody with that disease. Think of something that shows us that now it's abnormal. You have a patient with COPD that has green sputum. Is that reportable and why? Patient with COPD has green sputum. Is that an expected finding, or is that something we need to report?
It's expected, isn't it?
Sounds like they might be having an infection.
So you can have COPD and not have an infection. They're prone to infection. Green sputum is a sign of an infection. That's reportable. We wouldn't want to call and tell them their oxygen saturation is 91% and they've got a barrel chest. That's an expected finding for somebody with COPD. So ask yourself, what's expected for somebody with hepatitis and cirrhosis? What are the manifestations that we typically would see? And then what is a sign that either something is getting worse or they're developing a new complication? Those are what's reportable. And you're going to see these priority to report to the provider. So you have to ask, is this expected, or does this let me know something's getting worse? So with liver failure, they end up getting that buildup of ammonia levels. And so the treatment for it is to administer lactulose. You have to monitor patients' lab values, including their potassium. So when you administer lactulose, it increases stool and they can start to lose potassium. So we would expect that we would start to see potassium levels dropping. So we have to watch those closely. And being that we know what high ammonia levels will affect, we just talked about the brain, we have to be doing very thorough neuro assessments on this patient with liver failure or liver disease, because we're looking for changes in LOC. We're looking for signs of asterixis. We're looking for fetor hepaticus, which is when their breath starts to have a fecal odor to it. Those are all signs that now something is getting worse. They're having a complication. All right, peptic ulcer disease. Remember, when you see peptic ulcer disease, that is anywhere involving ulcers in the lower esophagus, the stomach, and the first part of the small intestines, the duodenum. So it could be a gastric ulcer. It's still peptic ulcer disease. So manifestations of that are related to where they are, where the ulcers are found. Typically, patients describe it as a gnawing type of pain. It's like this grabbing, gnawing pain. And most of the time where they feel it is that mid-epigastric area. And they can often get radiation towards the back. So gastric ulcer, where are these ulcers located? Gastric.
In the stomach?
In the stomach. So think about it. You have ulcers in your stomach. When would you expect to see pain if the ulcers are in the stomach?
So after a couple hours.
So you swallow food, food goes down the esophagus into the stomach, and then remember, we've got chemical digestion going on and we have mechanical digestion. So it's probably going to happen pretty soon after you've eaten, because you got ulcers in there, and its job kicks in fairly quickly once we swallow the food. So with gastric ulcers, you're going to see pain pretty much immediately when they eat. Now, hopefully they don't have dumping syndrome where the contents move too quickly. You would expect the duodenal ulcers to start hurting a couple hours after they've eaten, because that's the process of food leaving the stomach and going into the first part of the small intestines. A lot of times they get woken up in the middle of the night with discomfort. So pyrosis, vomiting, they can have constipation or diarrhea and bleeding. So what are we looking for in patients with peptic ulcer disease as evidence of bleeding?
Low H&H.
H&H changes, right? So hematocrit could start dropping. What else?
Change in stool color, depending on the location of the ulcer. So if it's higher up, it'll be more black. If it's lower, it would be more fresh. Red.
So peptic ulcer disease, is that higher up or lower?
Those would be higher up, so it would be darker.
So change in the color of stool, it could be dark, right? What if your patient is potentially vomiting?
It'll be bright.
Coffee
It'll be
brown.
like red. Coffee
It could
brown
be.
looking.
It could be bright red. So if they've got gastric ulcers that are actively bleeding, they could have hematemesis for sure. If it's coming a little bit lower, then it could be more coffee ground in appearance. So a lot of times patients will have an NG tube placed and it'll be hooked to low intermittent suction, and we have to be monitoring what's coming out of that. So if you see frank blood, what's frank blood?
New fresh blood.
Bright red.
Bright red, this is blood. There's no question about it. So frank blood could mean that the patient has an active hemorrhage. They could even have an ulcer that perforates. Remember, the ulcer starts digging into the mucosa of the stomach. It can actually get so deep that it penetrates the entire layer of the stomach tissue. And so now we have a perforation. Now what are we looking for? Or what are we worried about?
Couldn't that like infect the peritoneum?
Correct. So they could develop peritonitis. They could develop sepsis, hypovolemic shock. So these patients often have bleeds. Sometimes it's not, it's not considered to be a hemorrhage, but H&H is typically low. They need blood transfusions. So we want to be picking up on those signs of bleeding. If a patient has a surgical procedure for peptic ulcer disease, then you can, in the NG output, you can see scant blood. What does that mean, scant?
A small amount.
Yep, because if you've ever cut yourself or had surgery, you typically have oozing from the surgical site. It doesn't just stop bleeding when you leave the OR. So we would expect for there to be some blood mixed with the normal stomach fluids. So for 12 to 24 hours after surgery, we would expect to see scant blood. Emergency care for an upper GI bleed, and that is doing frequent assessments. You want to be assessing their pain and their vital signs, because that is what is going to give us those first subtle changes. So if a patient starts bleeding, what are we going to see vital sign wise?
Lower blood pressure.
Drop in blood pressure.
High heart rate.
Increased heart rate.
Increased heart rate.
They'll maybe be pale, cool, and diaphoretic.
Okay, so they can start to be pale, cool. They can become diaphoretic or clammy. They may become tachypnic because they're losing blood. And if we lose blood, we're losing oxygen. So all of those are indicators, because you may not see the blood outward. It's happening inside of the body. The abdomen, what are we going to assess for in the abdomen if the patient is hemorrhaging? Maybe they've perforated.
Distension.
You could see abdominal distension. How's the patient going to be feeling in that area?
Painful, tenderness.
So peptic ulcers are painful in and of themselves, but if they get a perforation, it's probably going to be an increase in their pain level. So that's why assessing their pain is really important, matching it to what's going on with their vital signs. So oxygen, they may get put on a ventilator, and it's these patients, if they are hemorrhaging, are most likely going to need a blood transfusion. So you can't transfuse blood. Blood is very viscous through a small catheter. So you want a large bore IV, and typically you place at least 2 of them because they're going to be getting fluids. They're probably going to be getting blood product in order to replace what they're losing, because it can put them into hypovolemic shock. Any findings you report, get the patient ready to go for surgery. A lot of times they can repair minor bleeds endoscopically. So they can go down, they can cauterize the area of the bleed. Some of them will be going to the OR, but we're going to have to be replacing fluid and blood. We're trying to maintain their blood pressure, because what is happening when that blood pressure gets really low? Body-wide.
Organ failure.
The patient can go into organ failure because cardiac output is being affected, which is going to affect perfusion to all of the organs and all of the body tissues. And so then the patient can start going into kidney failure and other organ failure. So we've got to try to maintain that blood pressure and replace what they're losing. NG tube will be placed. Saline lavages can be used as well. But a lot of times they will be going for surgery very soon. Diabetes insipidus. What do you remember about this topic? Anything you remember?
Dehydration.
Okay, you're thinking dehydration. What else?
A lot of diluted urine.
Okay, dilute urine, and a lot of it.
Decreased ADH.
Decreased ADH, antidiuretic hormone. Where's this stemming from?
The kidneys.
Pituitary.
The pituitary gland. Remember, that's where ADH comes from. It's the posterior pituitary gland. So it's decreasing the amount of ADH that's being excreted, which is then affecting the kidneys. So manifestations are going to be that excessive dilute urine. So is specific gravity going to be high or low? Dilute urine.
Low.
Low.
Going to be low. When it's concentrated is when the specific gravity is high. They're going to be thirsty. You're going to see electrolyte imbalances because the patient's losing so much fluid. They're going to be thirsty, taking in a lot of fluids, but constantly going, even in the absence of taking in fluid, they're still losing a lot. So there's different types. Primary neurogenic. Let me ask you, what's the difference between a primary disorder and a secondary disorder?
Primary is when you specifically have that medical condition or disease. Secondary means you have it because of something else, like
Correct.
another disease or process is causing that to happen.
Absolutely. So primary neurogenic is a lack of ADH caused by something in the hypothalamus or the pituitary gland. That is the primary issue. Secondary is caused by a tumor, an infectious process, head surgery, head trauma. All of that can affect the pituitary gland and then affect the hormones that are excreted from it. So that's secondary. Then the third one is nephrogenic, which is when the renal tubules in the kidneys don't react to the ADH. That can be a result of kidney damage. Sometimes it's hereditary, or it can be related to a medication. And so the two medications that most commonly will cause this is lithium and then demeclocycline, which is a derivative, I believe, of tetracycline. So risk factors are going to be the things that we know cause it. So head injury, head surgery, if they have a tumor, those are all going to increase the risk of them developing a problem with ADH. And then taking those two types of medications can cause it as well. Heart failure and pulmonary edema. And the question apparently was regarding home care. So you've got heart failure and pulmonary edema. What are you thinking about these topics? What do you remember?
Left-sided heart failure will cause the pulmonary edema.
Yep, leads to pulmonary edema. So there's your correlation. Okay, what else?
They might have
Fluid restriction.
What restriction?
Fluid restriction.
Okay, they may be on a fluid restriction, you're saying?
Yeah, like
Yes.
essentially like there's a whole bunch of water in your lungs, so you're gonna be on diuretics.
Okay. Kendrick, I think you had one.
Oh, I was going to say like the pink frothy sputum.
Okay. Frothy sputum, pink in color. So you got to kind of remember what's happening. It's left-sided heart failure. You're getting backup of blood, congestion in the pulmonary vessels. You're going to get an increase in the capillary permeability. The fluid's going to shift into the alveoli, including blood products, makes it pink. So we know the manifestations that are going to come from this, right? So when a patient has been diagnosed with this and they're getting ready to be discharged, you still want the patient to remain active, but they should not start any new exercise program without consulting with their doctor first. Why is the recommendation to consume diets low in sodium? What does that mean?
Because where sodium goes, water follows.
Yeah, the more sodium you consume, the more fluid you hold on to. They have an issue with extra fluid. It's not being seen systemically because it's left-sided heart failure, and that's going to cause an exacerbation of their pulmonary symptoms. So low sodium foods, some patients may have to limit the amount of fluids they consume. And you have to think about foods that are high in sodium. So what are some things you would tell people to watch out for?
Fast food, canned foods.
Yep. Fast food, canned foods, frozen foods, things that people may not realize. Salt is like a preservative. So even though things may not taste extra salty, a lot of times the salt content is off the charts. So, and these things often are cheap and they're readily available. So we really want to make sure they know what they should be eating, what to watch out for, get a dietary consult so that they can learn how to read nutritional labels. They should not smoke. They're having pulmonary edema, they're having respiratory issues. So smoking is only going to make that entire process worse. They also need to weigh themselves. And this really would be for anybody with heart failure, weighing themselves daily. What's the importance of weighing yourself? See if you're gaining weight or not, or what are we looking
See if you're holding fluid.
The fluid, because that could mean that the patient is having an exacerbation. So they should call their provider if they gain more than 2 pounds in one day or 5 pounds in a week. So they need to, do they have access to a scale? That's something we need to assess. And they need to keep a log of how much they're weighing each day so that they can see if over the last week, have they gained more than 5 pounds. Any swelling of the feet or ankles, shortness of breath, or chest pain are reportable. That means they are retaining fluid, which is going to exacerbate their symptoms. As far as medications, we have to make sure they know what they're taking, when they're taking them. This is an indication that even though they feel better, they can't stop their meds. So we need to instruct them in that. You may start feeling better. We hope you do in the next couple of days, but you have to continue on the medication or your symptoms are going to return. And then we just want to make sure that we educate them in, effective breathing so that they're keeping their lung capacity up to speed, trying to improve their ventilation and all of that. Preoperative nursing care, client who has alcohol intoxication. So what do you remember about caring for a client before surgery? Preoperatively, anything?
They have to be competent.
Why do they have to be competent?
So that they can give informed consent.
They have to sign informed consent. That's a huge portion of it, right? So we, as a nurse, have to make sure the person signing consent is competent. And so it could be your patient has indulged in some sort of substance, they're under the influence of narcotics, anything that affects judgment. And this has happened, I can't tell you guys, more times than I can count. Or you may have a minor whose family member is intoxicated and they're the one that has to provide legal consent. They can't sign it, right? So this is what we're concerned with. Who has to provide informed consent?
The patient.
Not the patient. Who has to?
Oh, you mean like who's giving it? The doctor.
Oh, the doctor.
The doctor.
Correct. The provider, not us. Not us. The provider. And so what's included in informed consent?
What the procedure entails, what are the risks, and what are the options if they choose not to go with the procedure?
Yep. Risks, benefits, options, including doing nothing. That's always a patient's choice. So the person has to be competent to understand all of that information. Just because they can physically sign the consent form does not mean that they understand what they are signing. And so as the nurse, you're confirming that the patient is competent to do that. So your patient that you're getting ready to admit for surgery is clearly intoxicated. You're smelling the alcohol. What do you do? What are you going to do?
Inform the provider.
You need to inform the provider. They're on the books to go to the OR. You're admitting them. They're clearly intoxicated. And then so they can't sign informed consent because they're intoxicated. But what else is really important about this?
Well, that like anesthesia and them being intoxicated is not good.
No, exactly. So those can mix and it can be life-threatening. I think I've told you guys this story, but I had a patient, we were doing, we basically did general anesthesia. We were using propofol. It was for an oral surgery case. And I think the patient was around 18 years old, and we induced the patient under anesthesia, and within minutes, he was profusely sweating, became tachycardic. We were concerned even that he was developing malignant hyperthermia. We had to abort the surgery, wake the client up, and then come to find out as he was waking up, we asked him, you know, did you take anything this morning? He had used cocaine the morning of his procedure. And so when we induced him with the anesthesia, the cocaine and the anesthesia were never meant to be put together. And it could have ended up being fatal for him because he did not divulge that information. And it wasn't readily apparent that the patient was under the influence of something. Very scary. And it can be life-threatening. So if your patient has been drinking, even if they're not the one doing informed consent, it can be life-threatening. We need to let the provider know, hey, we suspect that this patient has taken pain meds, or maybe they tell you they took, 2 Percocet before they came. Technically, that can impair their judgment.
So what do you do in this situation? Like you just, because I remember that being an ATI question. So do you just cancel the procedure and then?
So we don't, but we notify the provider. And then the provider typically will come to the bedside, evaluate the situation, and then cancel the surgery.
Okay, thank you.
So nurses typically don't have that authority, or you can tell your supervisor, but you need to let the provider know because they're expecting to go to the operating room with that patient.
Okay.
And they need to be aware of the situation because it can be dangerous. Patient's going to be taking pain meds. So we really they need to do some counseling with the patient so that they're not mixing alcohol, other recreational drugs with whatever medication they may have. But it would not be safe to move forward. What do you remember about left-sided, or let's take the left side out, cardiac catheterization? Remember, cardiac cath is the same thing as a cardiac angiography. What do you remember about this topic?
They're going through the femoral artery, so they have to keep their legs straight for like hours after the procedure.
Okay.
Check their peripheral pulses on both and compare.
Okay, so checking peripheral pulses and comparing. What else?
Temperature.
Applying pressure above the site after it's finished, after it's removed.
Yep, you got to apply pressure. Sometimes that's manual pressure. Sometimes it's by way of a pressure device, a bean bag, but pressure has to be applied to the site. And then I heard
the one where they can't be submerged in water. Or am I thinking of something else?
So usually probably for at least 24 hours, they can't. I heard temperature, I heard pulses. So remember your neurovascular assessment. So you want to make sure distal to the site of the access that the patient has feeling, they can move, that their temperature is normal, and that you can feel their pulses. Because what are some complications following cardiac cath?
Infection?
It can become infected.
Would it be some sort of a block?
Yep, so they can develop a hematoma, which could occlude, and this is the femoral artery. So where's the blood going?
Down.
To your feet?
Yes, to the lower extremity and to the foot. So if the femoral artery develops a hematoma or dissects, opens up, and now the patient's hemorrhaging, you're not getting blood to the distal aspect anywhere lower than that access point. So those are just really important. Now, it's not only through the groin. That's one of the most common locations. You can, a lot of times you'll see them accessing through the radial artery as well. Same concept. Radial artery feeds the hand and the fingers. So you'll see it very frequently, though, being the groin. Make sure that the patient knows when they inject the dye, it's an angiography procedure. So once they get the catheter in place, they make their way to the heart. They're going to inject dye so that they can watch blood flow to the heart. And when they inject that, the patient may get a warm sensation or a flushing feeling. Always nice to let somebody know what's to be expected. These patients aren't asleep. They are typically sedated just so they're comfortable, but they answer questions. They'll respond if the provider asks or wants them to do something. So we just want to make sure that they're aware if they start to feel flushed all of a sudden that something isn't wrong. And then following the procedure, you have to make sure that adequate pressure is being put on the site. Same thing after a venipuncture. They typically don't just pull the needle out and you're on your own. A vessel is going to bleed until it clots off. So, and this is an artery, a large artery. The leg has to be kept straight. You cannot sit them straight up, because if you do that, it's going to be putting pressure on the access site and cause bleeding. And then that dressing will typically stay in place for the first 24 hours. So they're not to do any strenuous exercise. They will be told when they can resume strenuous exercise. They have to be, if they go home, they have to report any bleeding from the site. What would be the cause of chest pain, do you think? What would cause chest pain?
An embolism?
Yes. They can develop an embolism. So we have to tell them about signs and symptoms of a PE, shortness of breath, that chest pain, especially with the larger emboli, is when you're going to see a lot of difficulty breathing and that chest discomfort. And then checking the extremity, change in temperature, change in color. If it's left access, which apparently this one was, it's comparing the left to the right leg. And so we have to instruct them on that. So with a groin access, they can't lift anything more than 10 pounds. They cannot bend at the waist, because that's going to cause pressure on the access site and cause it to bleed, or do anything strenuous for 24 hours, or however long the provider has prescribed for them. A lot of times they're in our care, so we have to make sure we're looking. I think I told you guys the story of one of Greg's patients who had a femoral access procedure. It wasn't a heart cath, it was something else. And apparently the night of the surgery, he did fine with the procedure, no problems at all. The night nurse never checked on the patient, he bled to death. You have to be checking. And so if patients are going home, they have to check the site. There's a dressing in place, but you are going to be able to tell if the femoral artery is bleeding. So we need to instruct them on that, because it can be life-threatening. Patients can bleed out from this. So very important, legs stay straight. They're on bed rest for sometimes 6 to 12 hours. Nothing that is going to cause that area to continue to bleed. So client has a permanent pacemaker rhythm, right? So things that we're monitoring for and changes that you're going to see in your ECG, and you may have gone over this with Professor Stevenson today, is you're going to see a spike on the ECG where it is eliciting the electrical conduction. Because remember, patients who have pacemakers, typically their SA node, which is our intrinsic pacemaker, is no longer functioning, or it's not functioning well enough in order to keep the heart rate at a normal rate. So when you look at a patient's ECG, you should see a spike before either a small P wave. Sometimes you will see evidence of the atria contracting, and then the QRS complex. So you want to make sure that there are adequate pacer spikes in direction or in correlation to the P and the QRS complexes. Sometimes you'll see this one. I wanted you to see there's a little P wave that's evident. So it's just showing you that once the spike is, or once the pacemaker is firing, you're seeing evidence of the atria contracting, and then you're seeing the ventricular contraction, which is that QRS complex. So we need to make sure that we're looking to make sure it's capturing. Some of them only fire when needed. So the patient's heart will use the SA node when it functions correctly, and then when it needs it, the pacemaker will kick in. Treatment for hypokalemia. What's hypokalemia? And what are your normal values?
Low potassium.
Low potassium?
Below 3.5.
Okay, so what's the range? So below 3.5, what is the range?
5.
Yep, 3.5 to 5. So low potassium. What's the first thing you start thinking of with low potassium?
Heart.
Cardiac arrhythmias. What if it was high potassium? Cardiac dysrhythmia.
Still doesn't affect your heart.
Yep. So low or high potassium effects can affect cardiac. So this one happens to be low. So the treatment for it is usually going to be to replace the potassium. Sometimes it can be replaced orally. Sometimes we have to give it IV. Never give potassium IM or subcutaneous. That potassium, when you administer it, can be kind of painful to a patient, but it can cause necrosis. So we do not inject it directly into the tissue. It needs to be given intravenously. So if it is oral replacement, you would give or want the patient to consume high potassium foods. So you need to know what's high in potassium. I listed a whole bunch here. And these examples came straight from ATI. So we need to be mindful. A lot of times you'll be able to print out a sheet for a patient who needs to start consuming more of a vitamin or a mineral. Give them a list. These are the foods that you want to be consuming. IV replacement, we don't ever give it by IV bolus because it can cause the patient to go into cardiac arrest. So the maximum recommended rate for IV potassium administration is 10 milliequivalents per hour with a concentration of no more than 1 milliequivalent of potassium for every 10 milliliters of whatever the solution is. So it's pretty dilute, and then it has to go in pretty slowly so that we don't cause cardiac issues. But what would be important to monitor on a patient that you are giving potassium to?
The IV site.
The IV site, you're looking for any evidence of phlebitis because again, it can be irritating to the lining of the vein. So you do need to be assessing the IV site. You obviously need to be looking for infiltration because we just talked, it can't be given into the tissues. It can cause necrosis. So monitoring the IV site, making sure the IV is patent before you use it. And what about monitoring the patient on ECG? Making sure that we've got them on a cardiac monitor so that we can pick up on any changes that might be occurring. Burn care. This one was following an explosion, but if you remember with burns, there's different phases of burn injury. There's the initial phase following a burn. And remember, during that phase, the patient has obviously massive cellular destruction, but then they get really quick third spacing, which means fluid is going to leave the vasculature and go out into the tissues where it's not usable. So a patient following a burn and a major burn can appear very edematous, but are they overhydrated at that point?
No.
No.
Why? They look swollen.
Because the third spacing fluid isn't in the vasculature, so that the body doesn't recognize, hey, we have the fluid that we need, we have the volume that we need. That it's kind of like wasted once it becomes in that third spacing. We can't really use it.
It's not usable. So what is usable, what is in the vessels has gone way down. So what type of shock are we worried about with these individuals?
Hypovolemic.
Correct. And then also, what is the electrolyte that we see go way up immediately following a burn?
Potassium.
And why?
Because it's an intracellular, and it's going to the extracellular space.
Yep. Because potassium, Circle K, lives inside the cell. When you have cellular damage, potassium gets released. So now your patient is in a fluid deficit, massive fluid deficit. They're hyperkalemic. You can see low sodium. So we're getting electrolyte changes, we're getting fluid changes. A lot is going on. And then you start to see a shift because one of the first things we do for a burn patient is fluid resuscitation. We have to give them tons of fluid, sometimes blood products as well, get the usable fluids back up, because if they're in hypovolemic shock, it goes back to what we just talked about tissues and organs not perfusing, then they're going to go into organ failure. And then they're going to go into the other phases of burn injury where now the fluid is going to start to shift back into the vasculature. And then it's going to hemodilute the electrolytes. So you get all these changes that occur. If for whatever reason you're at the scene of a burn, then we want to extinguish the burn, extinguish the flames, remove whatever the source of the fire is. Always protect yourself first. remove clothing or jewelry, anything that could be conducting heat, which was going to cause further injury to the patient. And we do not apply ice to a burn injury. Cool water, cool running water if we have it, but not ice, because that can cause further damage. If it's a chemical burn, if you remember, there are certain chemicals you actually can't put water on because it can cause a reaction to occur. But a lot of times with chemicals, you're going to see to flush the area with copious amounts of water. Like if you ever get a splash in your eyes, you're doing an eye flush for like 15 to 20 minutes. Imagine having running water in your eyes for 15 to 20 minutes. Then we know the patient with a burn has lost their number one barrier to the outside world and to infection. So we try to cover that area with something clean so that it doesn't get more contaminated. And then patients have lost skin are going to have trouble thermoregulating. So we want to make sure we're keeping the patients warm. They're likely to become hypovolemic. And then we go into our ABCDE and providing treatment. So extinguish the fire. We don't want further damage from occurring. And then we go right into airway, breathing, circulation. As far as minor burns, we just want to make sure, burns are extremely painful, minor or major. Give the patient an analgesic so that they're comfortable, and then the area needs to be cleaned. Just mild soap, tepid water. You don't want anything hot or cold. So just like room temperature, antimicrobial ointment because they have an opening in their skin now. And then a dressing would be applied, but you don't want any dressing that's going to stick to the burn. So it does have to be a non-adherent type of dressing. Clothing shouldn't be over the area if it's going to be rubbing or irritating the burn. No butter, no greasy lotions on the area. And then one of the things we worry about anytime a patient has a break in the integrity of their skin is that they're at risk for infection. So just educate them on what to look for signs of an infection. And then we also need to determine if they need to have a tetanus shot based off of what they were exposed to with that burn. Major burns is that fluid replacement, IV pain meds. So that is what is going to be given. Remember with the IV meds, it's going to be frequent but small doses. That's going to be the best absorption for the patient. Thermoregulation, so we need to keep them warm. The GI system, they are prone to developing a paralytic ileus following a burn, as well as they can develop a stress ulcer in their abdomen. So NG tube is often placed for decompression of the GI tract because even though motility isn't occurring, they're still building gases. So NG tube will be put in. Indwelling catheter, which is also going to help us to monitor their I's and O's since we're doing all of this fluid resuscitation. We need to know when they're going in to that second phase when they start diuresing. So that shows us that the fluid is adequate, that now the kidneys are being perfused and they're going to start diuresing. So a catheter needs to be in place. And then we can also monitor what's coming out. If it's red tinged, it could be an indication that there's damage to the red blood cells or the muscles at that point. So a lot can be gathered from monitoring the patient's I's and O's. For abdominal trauma, you can go over these. This wasn't necessarily on your ATI report, but it's good information to review regarding what do you do when a patient has multiple trauma or abdominal trauma, and what type of trauma is it? So like if the intestines are protruding through the abdomen, what do we need to do if you've got intestines hanging outside of the patient's abdomen?
Just cover it with saline soaked dressings.
Correct. Do not try to put them back in the abdomen. We just need to keep them moist. So like saline soaked, sterile dressing, cover them, keep them moist. We don't want the intestines or the tissues drying out. Obviously with abdominal trauma, we're not giving them anything by mouth. They will most likely have an NG tube placed to decompress the stomach again. Massive risk of infection. So broad spectrum antibiotics will often be prescribed. They may need tetanus prophylaxis as well. What were they stabbed? Were they impaled with something? Most likely wasn't sterile. Most people don't use sterile knives when they commit injuries such as that. And then we're looking for all of the complications that can occur. Shock, blood loss, infection, peritonitis, evisceration of an abdominal wound, all that good stuff.
Can I ask
Yeah.
Sorry, can I ask one question about the slide before?
This one?
No, the abdominal one.
Yep.
It says NPO, NG, or OG tube. What is that?
Oral.
I'm sorry?
Orogastric.
Orogastric. Okay,
So
thank you.
mouth to stomach versus nose to stomach. Yep, but it's all going to be for decompression. Brachytherapy, again, remember with brachytherapy, they have radiation internally. So we have to protect ourselves. We have to wear our lead apron around the patient. We have to wear our dosimeter badge. Certain individuals can't visit patients with brachytherapy, kids, women who are pregnant. We have to limit the amount of time somebody spends with the patient. We have to rotate nurses, rotate caregivers so that you're not always taking care of patients who are essentially radioactive. And then if for whatever reason a pellet were to become dislodged, there is going to be strict parameters as to what to do with that because it is radioactive material. So there's going to be tongs that you use. There needs to be a lead container in the room to protect the pellet once we put it in, that anyone around that won't become irradiated. Hospital protocol will dictate how that goes, but just make sure that we're keeping people who are visiting safe, we keep ourselves safe, we limit the time we're with the patient. Amputations and body image disturbance. This is a huge one. I see this one come up time and time again. So just make sure that we understand, patients who have an amputation are probably going through all of the processes of grief. Nobody goes through the stages of grief in a linear format, and not every patient is going to progress like anyone else. So we need to be mindful of that. We need to be allowing them to express their feelings. Their self-esteem can be impaired by that. They may not be motivated to want to care for the site or go to rehab. So those are all things that we need to be on alert for. We need to be on alert for signs of depression. We may need to set the client up with resources for therapy, counseling, spiritual advisor, because again, they have lost something. They will be grieving over the loss of a body part. So we need to make sure that we're giving them time to adapt at their speed and then intervening when needed. Accessing and flushing an implanted port. This will go along the same lines of a central line, a PICC line. Remember, they're all inserted, whether it's in the upper arm or in the subclavian. The tip of the catheter is going right into the superior vena cava. So if it's being used frequently, it's kind of like an IV line. If something's constantly being flushed through it, then the risk of it occluding or forming a blood clot is probably going to be low. But we need to make sure that we're flushing it with heparin. It's usually 5 mLs of heparin every time we use it, after we use it, or if it's a line that's in place that's not being used, at least once a month, or otherwise it can become obstructed. If you're ever trying to flush a port and you feel tension, what should you do? You're pushing on the plunger and you're getting a lot of force back.
Don't force it.
Do not force it. What do you want to do? Call the provider, because they'll probably order like TPA and break up whatever has developed in there. You don't want to force it, because if you force the plunger, you can dislodge a clot. And now it's going right into the heart. So the patient can get a PE, they can develop a stroke. So it's real important. And then these have to be accessed sterilely. So patient has a mask on, you have a mask on, it's sterile access. You have to cleanse the site. So remember, the implanted ports are under the tissue. So you have to cleanse the site before you access, and you access with that Huber needle. And this is a picture of the Huber needle. You don't just use any old needle. So it has to be a non-coring needle in order to access it. Hemodialysis, monitoring the patency of the graft. Remember, you want to feel for a thrill or a vibration. So when you palpate it, you should feel a vibration, which is the blood going through a turbulent area. and then the presence of a bruit. So if you listen with your stethoscope, you should hear a bruit or a swishing noise. Also, the grafts are typically placed in the forearm. You got to make sure you're assessing distal pulses to make sure that the patient's perfusing well, there's not an occlusion or a problem with the fistula. PICC line, they should not immerse in water. So if they need to shower, remember the PICC line is going to be in the upper arm. They need to cover that area and then avoid getting it exposed to the water. And then anybody who has a central line, a port, or a PICC line cannot have blood pressure on the side of the access device. They cannot have venipuncture on the side of the access device. So we need to instruct them on that so that they can make sure to tell anybody you cannot use this arm for blood pressure, and they should be marked. No blood pressure, no venipuncture on this extremity. Asthma pathophysiology, make sure you know the 3 things that are occurring when a patient has asthma. You're getting swelling of the mucosa, bronchoconstriction, and an overproduction of secretions. You should have access to this hyperlink. I know it's like 12 o'clock, bear with me, I'm almost done. Review the peak flow meter. What is that measuring? And that's, remember, you're going to blow hard and fast into the peak flow meter. So it's the expired air on a forceful exhalation, but there's a video and it'll show you a little boy who's using it. And then you want
the highest, right?
Yeah, you do it 3 times and you take the highest one and then you plot it on the graph. Okay. And you do that every day. So what this is showing is the effectiveness of the asthma treatment. So if their peak flow numbers are low, then the doctor may need to tweak something, or the provider, because you should be able to be getting better airflow than what you are. So every day they do it 3 times or whatever their prescribed amount is, take the highest number, they plot it, and then they bring that with them when they go for their checkup with the provider so they can see where their numbers are running. And then the last part is on blood transfusions. You can review this on your own. I guarantee you that will be something you're asked about. And one of the big things is to understand the process of administering blood products, who needs to be present, and then what to watch out for. How long do we stay with a patient when we start delivering blood products?
15 minutes.
Minimum of 15 minutes, because if a reaction is going to occur, it will typically happen within that time frame. And then when to stop the infusion. So if you start noticing some signs and symptoms, it can mean that there is a transfusion reaction occurring. So then I listed out the different types, when you will see manifestations, and what type of manifestations to look for. So just make sure you review that. Again, this was super superficial. It was the most missed content on your first ATI, and please make sure you do 1 targeted assessment every day, and that is going to help to prepare you for your Med-Surg ATI next week. I think that will be a huge benefit to you. I will send you all the link to the meeting for Thursday. It's Thursday from 1 to 2. You're welcome to attend. And if you're not going to be able to attend and you want to watch the video, then please email me separately so that I can add you as a member. Otherwise, I don't think you're going to be able to see the video. And that's all I got for you guys.
Thank you so much.
You are welcome.
Thank you.
You're welcome. So enjoy your lunch, and I'll see you in an hour for class.
Thank you.
You're welcome. Can anyone stop the recording? It looks